Good morning, everybody. My name is Deirdre Healy. I'm a partner in the Manchester office at Irwin Mitchell. My colleague Natasha Fairs is going to join us. She's en route into London because her Wi-Fi's gone down, but she's also going to join me to host today's event. A very warm welcome to you all. We're really excited about today. We've got some really excellent top expert speakers who are going to address you for about 30 minutes, and we'll give some time for questions afterwards. They are real leaders in their field of rehabilitation. I'm the national lead at Irwin Mitchell for rehabilitation. I'm passionate about it. The first thing I say to clients is, what can we do to make life better both now and going forward? So we came up with the idea of rethinking rehab as a theme for the conference because rehabilitation is ever evolving. There are new ideas. We've had 2 years of COVID where every practitioner has had to rethink how can they deliver their rehabilitation. And each of our speakers this morning is going to share with you their expertise. A little bit of housekeeping, just because I'll get into trouble if I don't tell you about it. We are going to be recording the session, so if you can't stay for all of it, don't panic. We'll send you a link and you'll be able to hear the rest later. We've got a feedback survey, so please take a few moments just to fill that in. It will be in the Q&A box on your screen. That will help us shape future events. And whilst we're remote today, and you can see I'm in a bedroom in my house, it would have been lovely to see you all chat over coffee during the breaks. And we're going to do that in September, on the 19th of September 2022. We're going to run another all-day conference where we can all actually see each other. Now, moving on to speakers, I can't tell you how pleased I am to introduce Miriam Duffley. I've known Miriam for several years. She is the director of the National Rehabilitation Centre programme and the Chief Allied Health Professional at Nottingham University. Her background is physiotherapy and specialising in neurological rehabilitation. She's passionate, a massive champion of rehabilitation. So I'm excited to hand over to Miriam now.
Many thanks, Deirdre, and good morning, everybody. It's an absolute honour and pleasure to be here. I'm going to talk to you about a new clinical model for rehabilitation, which we are developing and evolving both through Nottingham and the major trauma networks, but in line with the National Rehabilitation Centre programme. I'm not going to focus on that programme too much, but if you would like more details of it, my email address is at the end of this presentation. The partners along the bottom of this first slide are those clinical and academic partners who are involved in developing this new model. So just thought it was important to make reference to them before we get going. So if we move on, James, we all know the scale of the issue around the lack of capacity and in some cases capability of our rehabilitation services. We see it in our different professional days over and over again. Just to give some idea of the scale of this, there are some facts and figures which I'm not going to read out for you on that first slide, but the cost to our country and to other countries is astronomical in social and economic terms. The cost to individual lives is also huge when we don't get this right. And again, you will all be very familiar with that. I think the physical cost is huge, the social cost is huge, but the cost on people's mental health is also enormous, and an area that we haven't necessarily focused on in our services and explored to a degree that we really need to start focusing on. The major trauma system was set up in 2012, and that has been a huge success at the front end of that process. So we are saving more lives. I was involved in that setup, and the front end of that journey is now hugely successful and develops and produces a network of systems across the country that we can then tap into for our rehabilitation services. Because arguably, although the front end of that system is working well, we haven't done anything as a country to address the rehabilitation needs that come out of those additional lives saved, or indeed the existing people who weren't able to access rehabilitation services before that time. So capacity is a problem, capability gaps is a problem. Most of our services in rehab in the NHS are focused on neurological patients, but there are a huge number of other people who need rehabilitation in different ways as well. And actually the area of we're talking about in this presentation in our programme is that very immediate stage when people are still inpatients, they're still in hospital for other medical needs, but their rehab needs are almost paramount to those as well. So left unaddressed, things will only deteriorate further, people will lose out, people aren't getting back to life and work in any way, shape or form that they could do. I mean, Carol Black's very influential report in 2008 sadly hasn't been followed up, but that 175 million working days lost is staggering. The cost is huge, and I don't think we've really addressed that in any meaningful way to make that impact any less. The reality is that just looking at major trauma for a short time, 40% of major trauma patients need that intensive specialist rehab at the front end of their journey. And of that 40%, only 40% of patients are able to access inpatient services at the moment. That has a huge knock-on effect to their ability to return to life and work. We started a study in Nottingham back in 2013, which is now a national part of the TARN data collection set, looking at return to work rates following major trauma at 6 months. What we found is that only 35% of our patients were back to some form of employment, and that wasn't necessarily the job that they had come from or indeed in a full-time capacity. When we look at our peers in Europe and across the States, that figure is between 50 and 60% for a very similar cohort of patients. And in the military, who we're working closely with in the NRC programme, that figure is up to 80%. So regardless of how you look at this, there's a lot of work to do. And I also think there's a lot of work to do between building the bridges in a more meaningful and seamless way between NHS and the private sector in this field. We know that rehab is cost effective. The rehab spell through the NHS is at a cost of £39,000 on average, which is a very cheap intervention compared to a lot of other interventions that we make. And that saves over £500,000 in ongoing health and social care costs over that patient's and individual lifetime. So whichever way you look at this, it's a no-brainer in terms of socioeconomic terms, and it's a no-brainer in terms of returning those individuals back to their social and work functions. So what have we done so far? And if we could have the next slide, James, please. Having identified the issue and learned a lot more about that in terms of where our gaps are, we quickly looked at what the opportunities around that were and how we could build on the success of the major trauma system, not only in terms of how we identify patients who would most benefit from rehabilitation services early on, but also in terms of how we use that system and network, which is now established, to deliver a very different clinical model of rehabilitation across those patches. So what we did was look across the water both ways. We looked at how Europe and the clinical model there was working, how they were able to get those better outcomes. And we also looked across the water to the west, to the States, to also see what services they provide. Now, arguably, both of those services are funded in quite different ways and different again to the way we are set up. However, that said, there are lots of things that we can do very differently to improve our patient outcomes. We're very lucky in the NRC programme. We are co-located on a site which the Military Rehabilitation Centre is already established on and up and running. Headley Court closed a number of years ago and it's now relocated to the Stamford Hall Rehab Estate. So we're also working very closely with our MOD colleagues to develop this clinical model as much as we can. So what have we learned? So in Europe, the rehab journey starts very early on. It's recognised through us, the medical specialties, particularly in a much more robust way than we are doing at the moment, in that the patient needs rehabilitation with medical support around them. At the moment, the emphasis is still the other way around, particularly in those early days through NHS services, through critical care and through that journey through theatre over and over again into that high dependency area. We think very little about rehab needs at that point. In Europe, it's very different. The rehab needs are attended to right from day one with a very comprehensive team around that patient with the appropriate medical supports. And that's fundamentally the big difference of how things are approached. So how do we get that emphasis across in this country? And how do we really learn how our workforce needs to develop to support that way of thinking? In consultant terms per head of the population, we're the lowest across Europe in terms of rehab consultants, medical consultants, that is, per head of the population. And there's something about the rehabilitation specialty as an area of medicine that's not yet particularly attractive to go into. I don't think it's very well understood with our medical colleagues, and I don't think the impact of what they can bring to that patient's journey is necessarily well understood by other players in that team. So we've developed a model which front ends that rehabilitation right from the word go and tries to coordinate the pathway through those rehab services. At the moment, what we find is there's very long delays to get into what we class as a rehabilitation bed. It's a long way down a patient's journey. So on average, people are waiting 45 days at the moment to access a rehab bed in the East Midlands region, and we're no particular exception in the country. That's a pretty standard figure, by which point they've already been classed as medically stable, which has a variety of different connotations, but there's an assumption there that people need to be a long way through their medical journey before the rehabilitation starts, and that's fundamentally what we're trying to challenge in this new model. We are also trying to challenge the notion that it's only neurological patients who need this level and specialist input for rehabilitation. So we've broadened the access to rehab quite significantly, and major trauma has really helped us with that. In all honesty, there are many patients who are now coming through that system who have not got neurological injuries, which is a bonus for them, but actually we don't attend to their rehabilitation needs at all. So whilst there are long delays for neuro patients, there are actual gaps for lots of other people. So we'll come on to that in more detail later, but that is a real opportunity to improve our outcomes in the round. Europe also looked to partner much more actively with industry, with technology solutions, with engineering solutions, again, right at an early phase. So that's something that we're really exploring in our clinical models, so that how can we bring that expertise into the clinical solution for some of our patients for whom it will be appropriate. And working with the MOD, it's been very evident that they develop a clinical system which is a very intensive day, it's a very varied day. Sport plays a big part of their day, and that doesn't mean to say that people need to be doing that in they can do that in any capacity. So they make it fun, they make it varied. And the other big learning we've taken from the MOD is around attending to people's mental health. So whenever anybody enters the defence rehabilitation establishment, there is an assumption there that they are entering into that place with a degree of anxiety and in a degree of distress, because they have come from either experiencing a significant injury or illness. Our patients are no different, and but it's something that we don't necessarily address every time and in a very robust way. So that's very fundamental and central to our clinical model. The reality is that the NHS will never be able to provide the extent of rehabilitation that most people will need. And I do think there's a huge opportunity for us all to start working much more closely and collaboratively together with the private sector, and to make that journey between those two different services much more seamless, and arguably run one into another and get concurrent solutions. With the bonus that we can both use virtual platforms and digital solutions to try and do that. So lots of opportunities there. We are hoping to really reconfigure our clinical pathway so that patients have the ability to transfer through the different levels of rehabilitation which NHS England and local commissioners currently commission, and ultimately try and bring that commissioning function together, which would enable us to make the patient journey much more seamless and straightforward. So there are very high medically led rehabilitation units, level 1, which the number of beds are very scarce, and it's very, very difficult to access those at the moment. But by turning this model on its head, that obviously broadens the opportunity to have that very early intervention. But it's very unusual actually for somebody to access a level 1 unit and then travel through to a level 2 and indeed a level 3 unit in a seamless way. There's often long delays. Some people never make that transfer and are discharged from level 1. So actually there's a lot of work to do in terms of realising the fluency of that pathway. We are thinking of the National Rehab Centre as a pilot for this new clinical model, and after the first 3 or 4 years we will measure it carefully. We'll look at outcomes and we will look at length of stay particularly. And then hopefully be able to prove our concept and be able to roll that out across the major trauma network which already exists. And that's the bonus of having done that very extensive work in the in 2012 and beyond. What we've also done is learn from our European peers in terms of front loading the clinical assessment, and when people come into that rehab space, making sure that we've got our clinical experts really at that front end, so we're getting the initial assessments right from the word go, and developing a generic support worker role which is based on the exercise rehab instructor model that the MOD use, which are actually postgraduate sports and exercise medicine graduates. They've got a degree of knowledge in terms of anatomy and physiology, and with the right level of training and guiding beyond that into the clinical field, can start to write their own rehab programs and progress patients with that level of supervision. So our clinical model is very different again to how we treat patients at the moment, which is we don't use that level of expertise in quite that same way. So that enables the experts to really focus on where they need to be in that assessment and progression and planning of that management of that patient. What we're also looking at is a digital platforms and apps to enable virtual rehab intervention and wearables that we can start monitoring patients when they leave the centre and go back into their usual place of residence and home. Next slide, please. So the new clinical model really focuses on maximising the opportunity for rehabilitation on day 1, making sure that we are thinking about rehab needs alongside all of those medical needs and challenging solutions to that right from the early days. So right from intensive care, making sure that we're positioning people correctly, making sure that as soon as we can use different methods of standing people up, sitting people out, making sure people are moving as much as they can, making sure that the whole team is on board with that support. So it doesn't necessarily need to be a therapist who's doing that, and anybody who's making an intervention with that patient can make sure that that is continued. Right from the word go, having that focus on mental health, so really clear assessments of how people are doing, wrapping that around with some cognitive therapies and some psychological support is key, and that need will change from patient to patient obviously, but it will also change as they go through their rehabilitation journey. And what we've tried to think about is how we plan the environment in the new build in the NRC to really facilitate integration with other patients at the right point, but not pushing people too quickly, but also giving people the privacy and the space they need really to reflect on their new ability and new situation. So we really do want to streamline access to rehabilitation by making sure that the medical support around that patient is sufficient to access the multidisciplinary team around that. So that's where the rapid access comes in, and turning that model on its head completely, so that we're not waiting for that patient to be medically stable, whatever that means, to be able to really start their rehab journey properly. New roles will come into that. So I've talked about the exercise rehab instructor role already, but there are a huge amount of scope to support our medical workforce with ACP roles, with acute care skills, and junior doctor roles. We've got that wrapped around in a 24/7 physical presence in the centre, so that we can cope with patients quite early on. We can support tracheostomy patients, but also allied health professional consultant roles as well, to really manage that patient journey. And there are some great examples of this already working around the country, where the medical consultant is part of the team rather than leading the ward round and managing that patient journey. So lots of opportunity. In terms of targeting the workforce, we're really trying to think creatively about how we engage medical colleagues and nursing colleagues, particularly in this journey with us, because as I said previously, it's not a specialty that's seen as particularly attractive to go into at the moment. We need to turn that on its head. Hopefully with the more dynamic approach, with the technology interventions, we will make sure that that is a different perception. And then throughout the whole thing, that thread of returning to life and work, and really thinking about that from as soon as we possibly can. So we know that that's a really positive influence and motivator for people's rehab journey. Our goals should be set around returning to life and work where appropriate, and you know, we can really build some milestones around that, and that in turn, we know that work is a good marker of mental health and a contributor to positive mental health. So happy to take any questions on that, but what we've really tried to do is combine that whole approach, turning it on its head, so that the rehab comes as early as possible in that patient's journey with that medical support, and combining those technological and engineering solutions right from the word go. Next slide, James, please. In terms of the patients who we want to take through all of the rehab services in the future, that doesn't just stop at neurological patients, although there's obviously a great need for them. It does extend to, sorry, the slide's a bit bunched up, but it does extend to complex MSK patients and spinal injury patients, who we all know that wait a long time for rehabilitation at the moment, but also what we're currently working with one of our PhD students on, in terms of how we classify and identify patients who are very deconditioned from general surgery procedures, from long periods of maybe post-COVID or other illnesses, and who have spent a long time in hospital for specific needs, but actually have very much become deconditioned during that process as well. So we've started somebody off just recently, actually, on a PhD to try and define that in a more meaningful way, and we will be taking and trying to identify those patients early who would benefit from rehabilitation. Some post-surgical patients are staying very long time in hospital, 9 to 12 months in the worst case scenarios, and because they can't go home. So we really need to think about that differently and support them in a different way. Next slide, James, please. So one of the things we've learned from working with our MOD partners in all of this is the importance of embedding research particularly, but also training and education into the clinical arena. We've worked with all of our academic partners that you can see on the slide. So the length and breadth of the country, we've got universities interested in this, working with us to look at how we use that clinical space collaboratively to be an active research space, but also to provide that national level of training and education for the rehabilitation workforce. Now, this is great because this has borne great benefits in the military services and has allowed them to embed their findings from their own research very, very quickly into clinical practice. We all know that it takes quite a long time in the NHS to embed new research findings, and that really has to change, and rehabilitation is a perfect arena for us to do that in. We'll be doing a lot of research with patients in the centre, which is applied health research, which can very quickly translate into new ways of working and new ways of clinically practicing. So that's a really key part of this, and one that I absolutely hope will transfer out to the regional pathways as well, so that we get really good clinical trials going across the length and breadth of the country, and ideally internationally as well, to work with all of our rehab patients and develop a more comprehensive national database than what we can access at the moment. So those partners bring different things to the table. Some are very strong in the clinical field, but many of them are also very strong in technology and particularly in engineering. And the clinical engineering part of this is really exciting, we think. So James, next slide, please. So training the workforce is really key. As I've said before, we are developing new roles, and we are extending the cohort of patients in the NHS that will access this early clinical model of rehabilitation. So therefore we will need some training education around our workforce at the moment, and we will need to start, and have started already, in influencing some of the undergraduate programmes that enable people to come into this field of medicine. So we will be offering undergraduate placement opportunities. We'll be offering postgraduate courses, many on a virtual platform, which can be accessed from anywhere in the country, but also potentially anywhere in the world. And fellowship opportunities, both national and international, and this is really key, and will hopefully enable people to bring their own research ideas and work with us in the NRC, but also across the rest of the regional services when we do roll this out, to really embed that practice very, very quickly. We know that multi-centre and multidisciplinary trials are the most effective, and that's what this will be all about. So all of our patients will be asked to consent to be part of a research trial once they enter the rehab service, and hopefully again once we roll this out, that will be the case across the country. So that's a huge opportunity in terms of learning very quickly from this new clinical model what it could deliver. We also need to make the most of the great amount of data that we'll be collecting and can harness, and we already collect some really good data around rehabilitation, but don't necessarily always look at that in a way, I don't think, that means that we change our services and we're dynamic around that and responsive. So that's something that we'll be able to do much more meaningfully, as we'll have access to that directly. We're really keen to collaborate on a global scale with the training and education of the workforce, and certainly tap into some of the expertise around the rest of the world in this, and to do joint fellowship opportunities. So lots of exciting things to do. Much of that will be a focus on vocational rehabilitation as well, like we've already said. And really exploring the ways that we can get vocational rehabilitation into the clinical model as early as possible, and what training staff need to start thinking about identifying opportunities for those patients in how they work. So next slide, James, please. We've developed 3 research themes around this, really covering the whole patient pathway. This won't be, it's not rocket science, this is really quite straightforward. So right from the prevention and prehab stage, all this applies as early as possible, through the acute phase that we've been talking about this morning, onto the long-term and long-term rehab phase, but also maintaining that activity and making sure that in 6, 12 months, 2 years down the line, patients are still engaging with their rehab where appropriate, and we're supporting that journey. And the cross-cutting themes of applied research, tech and policy and economic impacts are really important, because what we want to do and what we really need to do is evaluate this service from all of those aspects. So the applied health research, as we've talked about, can get this embedded knowledge quickly into clinical practice. embedding technology and different solutions to support patients to be as independent as early as possible is key, and we need to learn as quickly as possible how we can advance that. And then putting that into policy is also very important, so that we change the systems and the healthcare systems properly in the long term, and we realise the economic impact, so people are abreast and aware of why it is so important for the country to get this right, not only for individual lives but also for the economic benefit of everybody. I'm conscious of time, so James, next slide, please. So really, just to sum this up, we've developed a clinical model which we're hoping to roll out in time across the whole country when we've proved the concept of this, working collaboratively with our academic and industry partners to completely change the face and perception of how rehabilitation is delivered, to access better solutions and opportunities and outcomes ultimately for the patients who require those services, and to realise that actually this is a very dynamic field of medicine to go into, to make it attractive, and to ensure that our patients have the best opportunity of, whether it's digitally, whether it's physically, whether it's cognitively, enabling them to go back into their lives in the best way possible, so that they can re-engage in their community and society and get back to work where that's possible to do so. We think this is a very exciting programme, and I would very much welcome any feedback on what we're trying to do, and any engagement from any of you that would like to be involved. Please get in contact. And I think that's the end of the slides, James, so thank you very much.
Wow, that's hugely exciting. Massively exciting and really sensible when you think about it. It's all plausible, but it's also a massive job, Miriam, isn't it? We've got a couple of questions that have come through while you've been speaking. The first one is, what's your view about rehabilitation services being based at the acute setting? I mean, let you speak about the NRC, but also across the country.
Yeah, no, thank you. That's a great question. So in what I hope I've made clear is that rehabilitation isn't a separate part to anybody's clinical journey through. So rehabilitation should be right from day one, whether that patient starts their journey in critical care or on a ward or wherever they find themselves. Rehabilitation should be front and centre of that process. So absolutely, it should be part of an acute setting, but it goes way beyond that, obviously, and in some cases we'll start before that journey in a planned way, and elective care will start from the prehab and preoperative stage. So we just need to totally change how we think about rehabilitation, and not think of it as a separate part to the patient's journey actually, and embed that in clinical practice all the way through. And I think when we do that, the outcomes will be staggering and we'll surprise ourselves actually.
Right. Next question, you've got a few, is has anybody looked at the resource allocation to different areas versus population need?
That's a great question. So when we looked at this, because resources are always a challenge for all of us, and what we had to do is, in the East Midlands case, make this resource neutral, if you like. So we haven't had any investment in this clinical model at all, and that's really important as a starting point, because actually we can do things very differently for no additional cost if we really start to think about things acutely. So by releasing patient bed days in the acute setting and transferring those patients quickly into rehab, we not only shorten the overall length of stay, we get better outcomes, and actually we save money by doing that in that way. And we not only save money for the acute trusts, but we save money on that patient's journey through health and social care, as you've already seen. So we don't yet know the benefits to this, but in terms of resource allocation, we did that in two ways. We looked at the pathway and where the delays were and the gaps and the unnecessary waits and non-value adding time. But we also looked at the impact on health and social care in that broader setting. And actually, one of the biggest challenges in this programme has been to get government to think about that in a joined up way across governmental departments, which is always a challenge, I think, when anyone's doing something like this. But we've tried to engage DWP and Culture, Media and Sport departments in this to a greater degree and less degree of success. But actually, we'll continue really pushing that, because this is a problem for everybody, not just for Department of Health and Social Care.
And you will have that body of data, won't you, that will be powerfully persuasive when it comes to those further discussions. And as you talk about that clinical model going nationwide, not just staying where you are. Yep. It's hugely exciting. Another question, should disability employment advisors be part of the rehab team? And if so, at what stage?
So yes, absolutely. Vocational rehab is hugely important in this new model. And I think at what stage is very much dependent on when it's appropriate for that patient to start really thinking in a meaningful way about getting back to work and how we facilitate that. So that will really vary. But we've got social workers and vocational therapists and occupational therapists in that team, whose role will be to identify when that support is needed and bring the right people into that conversation, because it will be beyond that, won't it? It will be also engaging with employers in terms of any adaptations at a really early stage, so that we try and coordinate all of this together for the person at the end of the day ready to go back into their place of work, and it's all set up and ready if there are those accommodations that need to be made. So no, absolutely, we need to really think differently about what that clinical team is in the broadest sense.
Great, excellent. Now there was a pre-conference question which I think you've covered, but just for the sake of completeness, I'm going to just put it to you to make sure that the person who raised it feels it's been covered. Can you elaborate on the differences in rehabilitation services in the UK versus Europe and USA? Can we learn from each other? I think you have covered that off. They're better over the waters, but please, can you deal with that too?
Yeah, sure. So in a nutshell, it's turning this on its head so that rehab is the focus of that patient's journey as early as we can possibly make it, and that we make sure the medical support is around that, but the focus is rehab. It's everybody's business. That's the second thing. Now, the funding arrangements are different both in Europe and the States, so people can stay in the system a lot longer. And that's where I think we need to be better at coordinating any NHS and private offerings so that that transition is much more seamless, and we're working together in a partnership to the best outcome for that person, rather than it being a bit disjointed, as in some cases it is at the moment. The other part to that is actually just the level of expectation, Deirdre, is just completely different. So people expect to leave rehabilitation when they are back to life and work in both of those places, rather than when they're safe to do so, which is how we view things at the moment. So that is a different starting point as well. And then our learning from the military is how we embed the research very much into that clinical practice and day-to-day activity.
Two very quick ones, because I'll get into trouble for not chairing carefully because we've got too many questions for you. Firstly, how do we get more hydrotherapy involved in long-term rehab due to such national shortage of availability? Well, you've talked about shortage of rehab consultants, talked about it's not being embedded right at the start of any medic's journey. So a quick one on hydrotherapy.
Okay, so it really has its place, completely agree. Unfortunately, we've lost a lot of the hydrotherapy facilities over the years. And this is in my view, this is a function of the lack of understanding of how important this is, and the lack of impact, again, into society and individuals' lives. So when we don't get this right. So I hope that by embedding the understanding in government of how important this is, we will start to see some investment in our clinical services, because we've done this programme without any investment, but actually we really do need investment in this, but we have to prove that it works first.
OK, there are a couple more. I'm going to move on, I'm afraid. We will come back to you by email, because we could be here all morning with Miriam, I'm sure, with the others. Really excellent. It's going to be a blueprint for everybody, isn't it? It will be like turning a juggernaut around once you get your data, I think. But how exciting that you're starting on that journey. Really excellent work. Thank you very much, Miriam.
Thank you. Thank you, everyone.
Moving on to our second speaker. I'm just double checking I'm on the right page. Bear with me. I'm really pleased to invite Dr. Ellie Okiri, consultant physician in rehabilitation neurology, based at Leamington Spa Hospital and also Hunters Moor Neuro Rehabilitation in Birmingham. Now, Dr. Okiri has been landed right in the mire, to be honest, because initially Dr. Barnes was going to speak to us and he's stuck in Italy. So poor old Dr. Barnes can't get out of Italy to join us in our conference, which is great news for him, I expect. But Dr. Okiri has agreed to step in and talk about medical cannabis in neurology, which is clearly a new innovation, Rethinking Rehab. So I'll hand over to you now.
Thank you, Deirdre. Thank you so much for allowing me to participate in this conference. James, can I ask you to make the screen bigger for me? I'm not sure why it's so small on my screen. Please. Can everyone hear me? Okay, so people say they can hear me. Can you make the screen bigger? It's quite small here from this end, James. Okay, so we'll just go with that then. Thank you again. The history of cannabis and its use in humans have been. Next slide, please, James. Thank you. The screen is still very small from this end. You're controlling it, but I was hoping that the scope of my talk will cover just a brief history, and then we'll talk about the Endocannabinoid System, ECS, a mention of phytocannabinoids, clinical evidence, talk about some side effects, contraindications. There may not be time for case history, but I think as we go along, I will probably cite some examples as we go along. And now, next slide, please. So the next slide. So the history of cannabis and its use in humans dates back to 3 millennia and probably even further back. And next slide, please, James. So it started from the Chinese and then spread across Eastern Europe and then eventually to North America and South America. Next slide, please. It was the Emperor Shennong, who is venerated as the father of Chinese medicine and agriculture, and was really known to have tasted several hundreds of herbs in China to evaluate and ensure that they had medicinal benefit. He also was in fact the founder of the current acupuncture that is quite popular at the moment. Next slide, please. And I don't understand China, but still talking about the history, as back as many years as 1550 BC, the oldest fully intact medical text was the Ebers Papyrus, and in that you see a word, I can't pronounce that word, Shemshemet, which implies cannabis, so which means that cannabis has been around for a long time, and that's been documented in that history book. Next slide. Next slide, please. Even Herodotus of Kallinossus back in 450 BC was quoted to say that the people take this hemp seed, creep into the tent and throw the seed onto the hot stones, and said they enjoy it so much that they have pleasure. Who wouldn't want to have some pleasure? Next slide. And then and I think this is, judging by the name, this Irish experimenter was started treating tetanus with Indian hemp in 1830s. Next slide. So Sir William Osler, who is considered as the father of modern medicine, suggested in his book, cannabis indica is the most satisfactory remedy, and especially migraines. That was what he alluded at the time, as far back as many years ago. Next slide. Even Sir John Russell Reynolds, who was the personal physician to Queen Victoria in 1890, was quoted to have, he said, if managed properly, cannabis is one of the most valuable medicines. Next slide. And as you can see, that between 1850 to 1937, cannabis was actually used as a prime medicine for more than 100 separate illnesses or diseases in US pharmacopoeia. Next slide. So what happened with all that great historical background and proven benefits thousands of years back? It was in the Second Opium Conference in Geneva in 1925, and the aim of this conference was to impose global controls over a certain range of drugs. Then Professor Guinde from Egypt, a delegate from Egypt, presented and secured the inclusion of Indian hemp with his unsubstantiated claim, suggesting that hashish, as it was known in Egypt, was at least as harmful as opium, if not more so. Next slide. So this was awful, and I think this guy, Harry Anslinger, from the first commissioner of Federal Bureau of Narcotics in the United States, was the one now who took it on and made a duty. Next slide. To run a very severe campaign against this botanical medicine, and these are some of the media campaign that he was suggesting that this may be handed over to you, and it was announced and circulated in several states of the United States. Next slide. And women cry for it, and men die for it, and etc. So there was a severe negative campaign against cannabis. Next slide. In 1961, the UN Single Convention came about and placed cannabis consequently in the same category as morphine, heroin, and cocaine. And at the time, they put it at Schedule 4, and Schedule 4 at that time meant particularly that drugs that are particularly liable to abuse and to produce ill effects, and such liability is not offset by substantial therapeutic advantage. So that was the way that it was scheduled at that time. And then, of course, they excluded industrial hemp, and nearly all countries were signatories to that scheduling of cannabis at the time. Next slide. In 1971, this UK legislation came in for the Misuse of Drugs Act, and cannabis was now classed in Class B. And everyone who was caught with cannabis was subject to 5 years in prison or or an unlimited fine or both for possession. The up to 14 years in prison if or unlimited fine or both if there was intent to supply other users. Next slide. So these are the brief medical background of the history of cannabis and how it became stigmatized so much so that people are still very wary about this botanical medicine. Now, next slide. Whether we like it or not, we all produce cannabis. We all produce cannabis. The endocannabinoid system that we'll hear so much about is essentially made up of a complex network of organs expressed in throughout the body, and then there are two key receptor sites: the CB1 type 1 receptor, that is the cannabinoid type 1 receptors, and the cannabinoid 2 receptors. There are also the CB1 receptors have quite widespread in the central nervous system, the immune system, reproductive system, gastrointestinal, the heart, the lung, and bladder. The CB2 receptors is not quite as ubiquitous as the CB1 and mainly found in the immune system. There are two other key chemical important compounds, the anandamide and the 2-AG. Next slide. So this is the makeup of the endocannabinoid system, but the mechanism of action of the endocannabinoid system is essentially that there's an inhibition. There's an inhibition of presynaptic neurotransmitters that releases the neurotransmitters and neuropeptides, and there's modulation of postsynaptic neurotransmitters and reducing the neuronal excitability. That's, in simple terms, what it says, and therefore the anandamides and the 2-AG helps to carry the bigger molecules in the central, in the presynaptic area through for the coupling of the CB1 and CB2 receptors. That's as much I can tell you. If you want, you can speak to the biochemist for the explanation. Next slide, please. So what does it actually do? What does the endocannabinoid system do? There is endocannabinoid system has for it to work, there's a selective inhibition, as I mentioned earlier on, of the neurotransmitters release. As a result, there is therefore the homeostatic control, giving the energy balance and energy metabolism in the system. The effect on adipocytes and hepatocytes and GI tract and things like that has been is well documented in literature at the current moment. Next slide. It regulates anxiety behavior, and in terms of memory, maybe in a role in extinction of old memories and short-term memory impairment. With respect to appetite, does increase appetite mainly through the CB1 receptors, and then there is a powerful anti-inflammatory role. In terms of analgesia, which is, we'll come to that, it probably also through a different receptor, because it's not just the CB1 and CB2, but those are the most popular. There is other receptors. So yes, it does also play a role in the thermoregulation and also promotes sleep and increases REM sleep. Next slide. Because of what I do neurological rehabilitation, I'm interested in this. There's a significant control of spasticity, motor control, and then therefore the use in spasticity. Neurogenesis and neuroplasticity is also been identified as some of the benefits. I've talked about the bladder earlier on, so there's a overactivity of bladder muscles is reduced and people have less incontinence. And the GI factors, hence it's used in inflammatory bowel diseases and so forth. Next slide. Now, there are two main strains. This slide is not showing very well. I don't know whether you've seen different slide. It's been cut out. There's the sativa and the indica strain. The sativa and indica, and really these days there's really no point of saying that a particular product is predominantly sativa, predominantly indica, as you know, the way they grow the products these days. Next slide. And there are you know, thousands of cultivars even made in chocolates and various forms that are being presented in shops across the world. Next slide. So in its simplistic form, lots of people do this in Canada and the US. There are people doing it illegally. It's less technical for extraction. This is just an extraction method. Next slide. Then, you know, slightly more technical is the ethanol extraction. Next slide. And the supercritical CO2 extraction. This is the most popular. This is one that most of, I believe, most of the licensed producers are using to produce the oil that we most patients are currently using across the world. Next slide. And then these are various forms of extracts. Apart from the oil that is very popular, there are things, cakes and things like that, that people have become familiar with the current moment. Next slide. Now, the final oil that is extracted is really largely, and the effectiveness of the oil and the bioavailability of the oil really is dependent on the carrier oil, which is either the medium chain triglycerides, MCT, or olive oil, peanut, hemp seed, grapeseed, the usual stuff that everyone knows about, but there are some of them may become allergenic to people, for example, if it's mixed with peanut oil. Next slide. And then again, the strain is important, whether it's indica predominant or sativa predominant, and people argue that the indica strain is more sedating, and hence people benefit from that for nighttime sleep, and the sativa is more uplifting. People use it to keep themselves more active during work hours. And then the final content also depends on the light, the type of light, and photo period changing of times, time of harvest, whether it's high buds or low buds, and so forth and so on, yes, as well as the temperature. Next slide. Now, turning to phytocannabinoids. So we talked about the endocannabinoid system, which is endogenous system. The phytocannabinoids is a plant, okay? And we've been talking about that. And then there are two key compounds that are much more popular than the rest of over 100 and something other compounds within the same botanical plant. The 9-delta tetrahydrocannabinoid is the popular THC, and there are other THC compounds. I won't go into that. The THC is a partial agonist of the CB1 and the CB2 receptors, and interestingly, it can also inhibit 5-hydroxytryptamine, which enhances glycine and activates GPR55. Next slide. So the THC, what does it do? The popular THC, which is the psychoactive property, which is reason for the regulations, which is reason for the stigmatization of this medicine, was first isolated in 1964 by experimenter Mitchell Lamb. It is psychoactive. It has an analgesic property. It is antipruritic. It gives a bronchodilatory property and neuroprotective property, as well as a very decent antioxidant, a muscle relaxant, an antiemetic. And I just want to also mention that it is a very, very powerful anti-inflammatory medication, 20 times more powerful than aspirin and 2 times more powerful in its anti-inflammatory property than hydrocortisone. Next slide. Still talking about phytocannabinoids. Now this is the non-psychoactive property, i.e. the CBD, the popular CBD. Hence, you have CBD everywhere in the shops, Holland and Barrett's, and across the counter. CBD is, or cannabidiol, has an inverse agonist action and CB1, CB2 inverse agonist action and CB1 antagonist. Interestingly, it also increases the 5-hydroxytryptamine receptor activation and inhibits adenosine uptake. Next slide. CBD, what does CBD do? CBD is neuroprotective. It is a very, very powerful anxiolytic, anti-anxiety. It takes the preferred drug and is very popular as an anticonvulsant, anti-epileptic drug. It has been said that due to its antagonistic property against TNF-alpha, it could be cytotoxic in breast cancer. It's also effective antiemetic, particularly in chemotherapy-related MSs. It is not psychoactive. It is actually better described as a non-intoxicating cannabinoid. Next slide. So it's not as simple as order, because there are next slide, many compounds. A total of 147 cannabinoids are known. James, I am actually not seeing the whole of the slide. I don't know, it's from me. And so I didn't know what people are seeing. Some of the slides have been cut off. Essentially, there are 147 cannabinoids. You have 9 types of delta 9 THC, and I think about 7 types of CBD itself. And then you have the CBG, CBC, CBN, CBT, then THCV, etc., etc. So these are all cannabinoids, and as I can say, 147. That's astonishing how they have managed to find as many in such a in one plant. Next slide. Again, as part of the phytocannabinoids, you have other properties apart from the cannabinoids. You have the terpenes. The terpenes actually gives away the odor, the smell, the smell that we all perceive. And then you have there are 5 key types of terpenes: the myrcene, lanolin, limonene, alpha-pinene and beta-pinene, and trans-caryophyllene. Now, interestingly, the trans-caryophyllene is the one that sniffer drugs are trained to identify. And so, if you are clever and you want to beat custom with your medication, you can extract the trans-caryophyllene out, then the sniffer dog is not going to catch you out. That's fascinating to know. Next slide. Flavonoids is part of what gives it the color. And there are 4 key flavonoids, apigenin, the conflavin, beta-sitosterol, and quercetin. I'm not going to go into details, but what is important in all of these terpenes and flavonoids is that they also contribute to medicinal value. They also have their own medicinal properties. You can see that even the apigenin is a powerful anti-inflammatory. It has anxiolytic property, estrogenic property, and etc., etc. And so this is the power, the nature of these cannabinoids that we're talking about today. Next slide. So what does that mean, really? When you have 140 something compounds within, and you start extracting them and isolating each one of them, that this is CBD, this is THC, you start losing the entourage effect. The entourage effect is really the synergistic effect that occurs when the whole of the plant is consumed together. And so you start losing those benefit, but they are. That's what's happening because of science. Next slide. So out of the 147 compounds, you have the 2 big ones, most popular, the THC and the CBD, and those are the molecular formula. Next slide. So the current formulations that we have clinically that are available to us is the Sativex. Sativex was first launched several years ago, about nearly 15 years ago, but soon died down because lots of commissioners were not commissioning the service. And then so Sativex comes in a 1-to-1 ratio, THC to CBD ratio, and then you have Nabilon, Dronabinol. Epidiolex is the one that NICE also approved in November 2019, along with Sativex. Sativex for the use in MS, and then Epidiolex for the use to treat intractable epilepsy in children, specifically Dravet syndrome and Lennox-Gastaut syndrome. Next slide, please. How do we take it, or how are patients taking it? I'm not going to mention smoking. Smoking is not recommended whatsoever. Vaping, spray, oral, and dissolvable medicine. Next slide. For vaping, better as less toxic components. It's the onset of action is in minutes and lasts 2 to 3 hours. It's got a very good bioavailability. Next slide. The vaporizer types that are recommended, there are a number of vaporizers where you've got different types, and there are cartridges these days. The manufacturing, next slide please, the manufacturing more and better vaporizers for its effective use. Next slide. Next slide please. The sublingual or buccal route is the oil, and holding it under the tongue for 1 to 2 minutes with fast absorption in minutes, lasting about 4 to 6 hours. The bioavailability really depends on how long under the tongue that you've been able to keep it there, because it's only about 20% bioavailability, whereas the vaping is at least 40%. Next slide. Orally as well, you can, for various reasons, some people have tasted it and they didn't like it. So if you take it orally, then the problem is that it's going to undergo first pass metabolism, and therefore the bioavailability will be dampened down. Next slide. I've mentioned Sativex is the only available spray at the moment that I know of. Next slide. And the dissolvable tablets. Next slide, please. Thank you. So in summary about how to take it, you have smoking is not recommended. vaping is better as it's less toxic. You got the edible tablets. You got the sublingual route. Next slide. Next slide. Yes, please. And then you have this, interestingly, the rectal and vagina pastries, and this one completely avoids the first pass metabolism, i.e. it's not broken down before it gets to the receptor site where it delivers its action. It's not broken down through the stomach. Next slide, please. And next slide, buccal patch. And so, in summary about the bioavailability, smoking just gives people, I did say and stress that it's not recommended. UK government does not allow us to do so. The variability is huge, 2 to 56% bioavailability, vaping 40, edible 6 to 20%, sublinguals 20%, rectal as much as 40% because of bypassing the first pass metabolism. Next slide. So what's the evidence for the use of this medical cannabis? I think it was Professor Mike Barnes and some of his colleagues that were mandated by the UK all-party parliamentary group for drug policy reform. And what they did was they reviewed online search engines and collected at least 20,000 references and ranked them according to the American Academy of Neurology. Next slide. And so they ranked them as class 1 study, class 2 study, etc. And class 1 study being a randomized controlled clinical trial with objective outcome assessment and blind allocation to groups. Next slide. So they graded it. They graded it after the so in terms of good evidence, moderate evidence, some evidence, and so forth. Where good evidence is at least 2 class 1 studies with a theoretical basis and other class 2, 3, 4 evidence in association. Next slide. And so what did they find? What they found was that for chronic pain, there was good evidence. I'm not going to go into detail about that because of time. There was good evidence for chronic pain. 11% of the population has chronic pain. And so if there's good evidence, hold your thoughts about that. And hence, of course, NICE approved Sativex for use in MS patients with pain. Next slide. And so for spasticity, they found good evidence from several double-blind placebo-controlled trials. There were good evidence that Sativex was helpful. Next slide. There was good evidence for anxiety. Interestingly, for anxiety, because THC has a biphasic effect, in low dose it is anxiolytic. In high dose, it can become anxiogenic. It can make anxiety worse. Next slide. So it was good evidence for nausea and vomiting in terms of in the context of chemotherapy, and there are some several formulations. There's been some Cochrane review about this one. Next slide. There was also good evidence for epilepsy in particular, mainly from the Epidiolex the trial in terms of Draves and Lennox-Gastaut syndrome, but we think that there's no reason why it should not be as efficacious in other epilepsies. I do adult epilepsy. I have at least 18 patients with adult epilepsy because I do adult rehabilitation neurology, and I have found lots and lots of my patients have settled down, and they indeed have benefited, reducing their other anti-epileptics gradually. over time. Next slide. So anticonvulsant phytocannabinoids is well known, and it's not just the CBD. There are other cannabinoids that, as I mentioned earlier on, that also possess the anticonvulsant, anti-epileptic properties. I've listed some of them there. It does include the terpene, lanolul. It does include the THCV and other types of, and including THC for that matter, which, as I said, has a biphasic activity, has anticonvulsant property for 62% of animal models, and then can also, unfortunately, trigger seizure. Next slide. Similar to what it does in anxiety. So this is this was the epiduralless research that NICE have used to approve epiduralless for use in children. 99.7% pure CBD, but with 3 milligrams of THC per 1,000 milligrams CBD. Next slide. So there was moderate evidence that was provided to the all-party parliamentary group, to the government, about appetite stimulation, moderate evidence, fibromyalgia, sleep disorders, but in practice, sleep is massively improved. It's not just moderate evidence, but next slide. There's also some evidence in other conditions, as you can see, including glaucoma. Next slide. So there was no recommendation to the government about dystonia, depression, Huntington's disease, OCD, headache, but the headache issue is very interesting because I have lots and lots of patients. Every patient that have come to the clinic with either migraine or headache have benefited massively, and they have had to drop most of their other medications. So people returning back to better quality of life. Next slide. Tourette's syndrome, there are recently 10 trials so far with positive results about Tourette's. Next slide. There's also some evidence of benefit from full spectrum CBD for those who have ASD. And the next slide, please. Thank you. Now, with regards to Parkinson's disease, the early studies are showing some efficacy, particularly for the motor symptoms of Parkinson's disease, the bradykinesia, the tremor, and the rigidity. I have had 2 patients who have benefited from their rigidity, but they were disappointed that tremor didn't settle down, but rigidity most certainly did. Then for the Alzheimer's, early evidence of improvement in agitation and anxiety, that I think this is all related to the anxiolytic property, the pain analgesic property that this medicine provides, and people are settled down better. Next slide. For the brain tumors, early evidence of efficacy in glioblastoma particularly, and I think there's some evidence that a combination of Sativex and the temozolomide was better than placebo. Again, the symptoms of somebody with patients with glioblastoma, for example, is again reducing the anxiety, reducing their seizures, better appetite, improved sleep, and improved pain control, obviously, and improve quality of life. Next slide. And traumatic brain injury, I do traumatic brain injury as everyday work. Again, there's no really hard evidence there, but what you find is that patients' pain is better, seizure is better, anxiety, sleep is improved, and so on. So these things are, this symptom control issue is repeating across various neurological diagnosis. Next slide. And so there are some of those. The overactive bladder is a very interesting one, and patients, particularly MS patients who have overactive bladder, have reported great benefit. Next slide. So talking about side effects, so the side effects generally are mild, especially short-term side effects, very mild and well tolerated. THC has much more side effects. CBD, really no side effect from CBD per se. It's the THC that is the issue. The main short-term problems is the dizziness, drowsiness, dry mouth, and disorientation. Those are the commonest ones. Next slide. So if you look at the heightened review of 62 studies, on top of that slide is disorientation and dizziness coming at the top with 5.4%, 5.4 odds ratio. Psychosis is really at the bottom, 1.09 odds ratio. Next slide. For long-term effects, schizophrenia or psychosis, this is an interesting one. Probably this can exacerbate symptoms. The cannabinoids can exacerbate symptoms in people already suffering from psychosis, people who are susceptible to psychosis, and probably reduce the age of onset of psychosis, but particularly when the early age of usage. So as you probably know, the brain size may be complete. The brain continues to increase and the size reaches its maximum size, but brain development continues into mid-20s, so average of 25. So if people use this medication before the development of the brain is complete, then they are more susceptible to complications and adverse reactions. But it's interesting note to say that 10,000 light male users and 29,000 light female users will need to stop cannabis to prevent one case of schizophrenia. So that's interesting. Next slide. So the other long-term effects is about cognition. I think for the same reason that I mentioned about cognition, decline of cognition, there's a limited evidence of long-term cognitive problems, and it's maybe related to early use when people start using it before their brain is fully developed. But look at whether cannabis, the dependency of cannabis, especially cannabis dependency syndrome, occurring in about only 9% of street users. By the way, most of those side effects are much more common in street users. That's where a lot of evidence have emanated from. In the prescribed, in the clinical setting, side effects are very, very minimal because you are very cautious what you're doing as medical prescribers. But if you compare the 9% of the cannabis dependency syndrome with 15% in alcohol users, with 32% in smokers, you can see where cannabis is in terms of dependency issue. Now, the issue about driving may come up, and I haven't been looking at what people are saying because I'm concentrating on the slides in the chat box. But driving is another issue whereby you have it can impair driving. CBD is free, you can use that, no problem. It's the THC that is the issue, and you need about 2 micrograms per liter of THC in your system to go above the legal limit. And this is interesting. This can happen quite easily, especially for those who are using THC more regularly as a regular regime. Next slide. So there are other side effects. Some patients have excessive emesis, and that's an interesting one. And then overdosage can cause increased heart rate, extreme anxiety, paranoia, and psychosis. Next slide. Next slide, please. Thank you. Contraindications, very quickly. So the absolute contraindications for me, and I think for most of us who are practicing in the UK, is psychosis or schizophrenia in self or first degree relative. And this is because of THC, and I've just mentioned that. The mania is also due to THC, and cannabis use disorder. Those who have cannabis use disorder is also contraindicated. Pregnancy, breastfeeding, we do not have strong evidence about this, but it's better to say similar to most medications, no pregnancy, no breastfeeding whilst using it. Next slide. Related contraindications, I have prescribed for patients who have had cardiac arrhythmia, but very, very, very cautiously. It is the high THC products that are especially the problem. And so a general rule is to start very small and go slow. Next slide. Next slide, please. Practical prescribing time is a problem for me. Again, as I say, start low and go slow. Generally start with buccal, oral, CBD. Some may need small amounts, 5 to 10 milligrams, but many may need as high as 100 to 200 milligrams, and so forth. And then if no effect, then I just add a bit of buccal or oral THC, starting with 1 milligram of THC, and then gradually titrate up to 20 milligrams per millimeters of THC. It's a very personalized medicine. So individuals, you tailor it to individual needs in terms of age, in terms of what the patient really needs. Is it a naive user, i.e. not been exposed to cannabis before, or is it a very experienced user? So it really depends on whether someone is experienced and you start them slightly higher, just getting them out of the street. And it's, for me, why I went into this, it's about harm reduction. It's about harm reduction because the street users are having all sorts of impact. Why not bring them into the clinic, prescribe it safely in a safe setting? And next slide. So essentially, in summary, using oral oils as a base of therapy, start with high CBD oil for daytime, add THC starting at nighttime periods to improve sleep, improve quality of life generally. Next slide. So in the UK currently, there are about 15 clinics, active clinics. There will soon be more, and then collectively, what we have seen is that about 60% of the patients are being treated for pain. 60%. The anxiety and PTSD, depression is more psychiatric issues, 20%. The rest of the patients, especially neurological, MS, etc., is contributing to 10% of the consultation across UK, and others 10%. Now, the majority of patients are requesting flower compared to oil, but largely because majority who have arrived are already experienced users. They were using cannabis previously, and the story is almost the same. They're coming to the clinic because they do no longer want the police to be after them, knocking at their door, looking at over their shoulders, and they want to be responsible, they want to be legal. And so we're having to use flower, which they are using previously. And that's why the percentage of flower that we're using in the UK is much higher than the Canadians. Next slide. Yes, thank you. I think I probably overran about time. Sorry.
Oh no, that's fine. That's fine. We've got a few questions. Hi, I'm Natasha Fairs. I'm an associate solicitor in the serious injury team in London, and I've got a few questions for you, Dr. Ferry. It's really fascinating talk, and I think everybody's really kind of just wants to know a bit more about your discussion. A lot of the questions are about management with certain conditions. One of them is, I note in your talk, you talked about pain is better in relation to brain injuries and controlled seizures. But there was a question about whether it is not counterintuitive to give cannabis to patients with brain injury and various neurological diagnoses who require rehabilitation. What's your position on that?
I did show a slide on brain injury, and there's no solid evidence, robust evidence about its benefit, but we know that cannabinoids are neuroprotective. They have neuroprotective properties, and that's why there's issue about neuroplasticity and neurogenesis. They do have a place, but there's no robust evidence about that. How does cannabis help people with brain injury? As I mentioned, the management of seizure is better controlled, precluding them from using conventional anti-seizure medication that causes brain decline and things like that. Their anxiety is better, they sleep better, their muscle tone is better, so quality of life is generally better with respect to those who are who have survivors of brain injury.
Yeah, exactly. Brilliant. And I think a similar question about spinal cord injury. Again, you said that it's good evidence that it was helpful, but how about in the rest of the world? Do they use it differently? I mean, obviously, like I've been to Canada and cannabis is used widely over there. Do other countries, are they a bit more forward thinking than we are at the moment in relation to cannabis use for medicine?
Absolutely.
Yeah.
I have two of my previous mentors. I had to be mentored for a period of about a year before I felt more confident. Each one of them have had about a minimum of 5,000 patients, so the experience is massive, and they're a bit more relaxed in the way they suggest the medication being used. In fact, they trust some of their patients. Some of them, the government actually even allows patients that the physician trusts to plant their own products in their own back garden and extract it themselves. But they are monitored, they're regulated in that sort of way. So we are still starting. It's only about 3 years. So we're lagging behind, but we're getting there. When we started, there was little or no prescriptions whatsoever. 3 years ago, September 2019. Now we have about, I think the total prescription so far is getting to nearly 15,000 patients within 3 years. The only problem is that majority of these prescriptions, or almost all of it, is in the private sector, costing patients a lot of money, unlike the Canadian system that government actually helps and support the prescription cost. And so I think we still have a long way to go here in the UK. I think the whole problem is that the stigmatization, people are getting more relaxed. GPs are sending patients summary of clinical records when the clinics request for them. Previously, you get very horrible, harsh emails and telephone calls abusing clinicians, the clinics, for parading drug meddling and etc. But it's getting better and better. People are beginning to have knowledge about the need and the benefit of this medicine.
Yeah, brilliant. Okay, thanks, Kevin. Just one question quickly before we go. Obviously, we're all about preventing accidents. I know that you said that it's the THC is the problem with dizziness, drowsiness, confusion when driving. Can you just confirm that people shouldn't be driving when they've consumed THC? But I think you said that CBD is fine, that you can drive with that.
Right, that's the driving is an interesting one. So the legal limit for THC is 2 micrograms per liter. And as I mentioned earlier on, it's very easy for those who are already taking THC for either pain or whatever symptoms they are treating. It's very easy to go over the limit. And so what we do is to tell the patient from time, if you need your vehicle to go to work and all that, you must therefore not take THC. Okay, it takes THC deposits in the fatty tissue and takes time to clear. It takes about 2 weeks to clear from the system through the urine, 40% elimination, the feces about 60% elimination. So it could take time. So if you're over the limit, 2 micrograms, very easy to be over the limit, it's a problem. So you've got to the individual have to change their lifestyle if they must if they must use their car and whilst taking medical cannabis. If, for example, you're driving and you are pulled over and they think that the police thinks that you are a bit drowsy and you're not poorly coordinated, that's also an offense.
Exactly. Yeah. Brilliant. No, that's been really, really helpful. And thank you so much for speaking with us today. There are a few more questions and we can email them to you and get back to people in relation to that. But what we're going to do is we're going to take a few minutes break and we're going to reconvene at 11:40 and go on with the conference. So thanks again, Dr. Arkeri, and we will see you in 5 minutes, so 11:40. Thank you.
Hello everybody again. We now have the wonderful Dr. Ganesh Bhavikati who's going to speak to us. Ganesh is the Consultant Clinical Lead in Rehabilitation at the Walton Centre, and if you haven't heard of it, you must be keeping under a boulder in life, because it's a global recognised championship of the field of neuroscience. Ganesh leads the team there. He's also clinical lead of the Cheshire and Mersey Rehabilitation Network, and they provide rehabilitation from the hyperacute setting, acute and post-acute, so covers the whole spectrum. He's going to talk about the rehabilitation prescription, and I have seen it in Walton Centre notes, which is sometimes people talk about the prescription being as rare as hen's teeth across the nation, but I can confidently say when I'm reviewing notes from the Walton Centre, it's in there. So over to you, Ganesh.
Thank you, Deirdre. Can you hear me okay? Can you put me thumbs up if you can hear me okay? Hopefully you're all able to hear me okay. I'm Dr. Ganesh Bhavikati. Thank you very much for a nice introduction, and no pressure on me. I just did a little bit of a change in a topic because Deirdre asked me to talk on rehab prescription. Is it being put to best use? I think I cheated a bit and just taken out the second part. There's a reason for it, because I think as a clinician, I can talk about what are the background. What is it? What are the facts, figures in my practice? How am I doing it? And my views about it. But is it really put it to best use? The best person to answer is the patient and their loved ones. And possibly you could add to it from the third person, from the people who are reviewing it, from that side of it. But so it is not for me to answer whether it's put to best use or not. I could say about what is it and what is the idea behind all this. So, and what is the hope we are in that how we could possibly help our patients. So next slide, please. So I'm going to talk about what I can talk about. That's the background of rehab prescription, where it came from, and how that's going on, what is my practice is like, and what are the possible benefits are, which is plenty, and what are the potential challenges are, which is also that we need to be aware of, because that is something, it'll be service delivery is not going to be easy one. Next slide, please. So what is it? So rehab prescription as an interdisciplinary team description. I have put this definition there, but in essence, when you see a patient after a major trauma, it is understanding the patient with their pre-injury life, how they were, and what is the injury now? What are the physical, cognitive, psychosocial problems patient suffering with? What is that interdisciplinary team help they need, and what's the likely progress is? Putting that all in one single document. That is rehab prescription. So having this in a single document is incredibly helpful. Hopefully that's the idea for the patient, their loved ones, and also for their GPs and the next care provider, which is majority of the cases, it's GPs. The prescription is an extension of discharge and transfer summary. Previously, majority of the time, transfer summary or the discharge summary was a short medical summary. I'm talking from the acute side, and in the rehab, always or majority of the places, we used to write a detailed summary, which was the case before, and we used to do that now too, and with the full multidisciplinary or interdisciplinary, however you see it, interdisciplinary team summary with the ongoing needs and ongoing referrals, how we are doing it. It should also include not only the clinical, but also the social care plan, health and social care plan, so that everybody can work from one document rather than duplicating or they're multiplying and patient getting or people in the either in the treating service or the receiving end getting confused. So it's supposed to be a one document with all clinicians dealing with the patients. That also shows patient after a major trauma or injury, as there are plenty of clinicians need to be involved, as we all know. and each one having their own notes is not going to be helpful. So all coming from a one unified document is going to be a simplified way and a better way and a more coordinated way. It will hopefully not only help the patient, but also the clinicians who are dealing with that, because we will invariably bring the staff together to understand the patient's needs. Next slide, please. So as you all know, the Clinical Advisory Group, also the CAG, in around 2010, when the major trauma pathway was designed, rehab is the forefront. It gives a very focus on early and ongoing rehabilitation, and early and ongoing rehabilitation by a multidisciplinary team, and the document is an evident of part of it. So it is a focus on high quality early rehabilitation. Patients admitted should have an early rehabilitation need to be assessed, documented, and provide that as an ongoing rehab prescription for the patient and the next care provider. Next slide, please. So there are two types, the standard rehab prescription and a specialist rehab prescription. So that the patients who come to a major trauma who thankfully not sustain a severe injury enough to go to a major rehabilitation or a specialist rehabilitation setting. So in an essence, they might have had an injury, they recovered well, thankfully, but they are going to go to community and they may not need an inpatient setting. Does not mean that they do not need a rehab in a community or ongoing basis. So that comes under a standard rehab prescription. And when the patients goes to a specialist rehab units, they will need even more, their needs and the complexity is likely to be even more. So they come with a specialist rehab prescription. This very likely to cover with a lot of times with a standard, multidisciplinary, detailed rehabilitation discharge summaries from, but this focuses on the timely and a unified way of bringing that in one detailed report. Next slide, please. So the BSRM obviously has taken the lead and has developed a pro forma. So obviously there is no nationalized document exactly how it should be, but there is a draft of which many centers have changed, or rather adapted to their own needs, and which can work in their own centers and can change into a paper copy or electronic system or into a pro forma which can work in their region better. So, but there is an idea about what are the documents should contain, what is the core principle of it, what are the core items and principles inside the rehab prescription should have. So let's look into that. Next page, please. So the specialist rehab prescription, as we said, it expands more in detail on the standard rehab prescriptions. It includes the nature and of the rehabilitation needs and the recommendations and referrals on ongoing basis. And these patients are very likely would require more complex and more prolonged rehabilitation needs. Next one, please. So this slide will show you that after a severe disabling illness or injury, trauma is only one among lot of injury or illness. So patients are very likely to be doing absolutely well or might have a pre-existing illness or over which they had a sudden one episode of insult, admitted to an immediate care, and following that rightly so in acute care where they have been saved and recovering. During early time, the rehabilitation care should be provided and a standard rehab prescription should be provided. And that goes with the patient to the next care, either GP or with the patients and to the next care provider with the standard rehab prescription. However, if the patient's physical, cognitive and psychosocial problems are so severe enough to admit to a hyperacute, acute or post-acute rehabilitation settings, names can be confusing depending on the region you're working in, because we can all use as different names, but technically speaking, level 1 hyperacute, acute, or level 2 or a non-specialist rehab settings, and when they has to be provided with the specialist rehab prescription completed and also being provided to the patient and the next care provider. Next slide, please. So in a 2019 guidelines says there are some integrity of it. This can bring into some difficulties in delivering it, even though it comes with a lot of good ideas. Sometimes the delivery could be difficult. The first rehabilitation assessment should take place within 48 to 72 hours of the patient's admission. The rehab prescription have to be completed for all major trauma patients who need rehabilitation at discharge, which is invariably almost all patients admitting to a center like as Walton Center, which is a standalone neuroscience specialist center. So almost all patients admitted with a major trauma to our center will require ongoing rehabilitation needs and will require all of them need to be completed a rehab prescription on time. All major trauma patients will require an evaluation, needs to be recorded in TAN data as well. This is a national data set for patients with the trauma, as you know. Next slide, please. The principles of a rehabilitation prescription. The rehab prescription must be developed and involvement of the patients, their family, and their loved ones. Can come with challenges to approach in the right time and how we can approach in some cases. Administered by specialist healthcare professionals in rehabilitation, and it must contain 8 core items. I will come to what it is in the next pages. And the rehab plan must be discussed with the patient where possible and copies provided for them, their GP and the next care provider. Completion of minimum rehabilitation data set, which is a part of TAN data as well. And all above record should be recorded in the TAN. This was the principle of rehab prescription, which we are all work towards and ensure that these are being delivered appropriately. Next slide, please. And the core items are, these are the minimum standard. This is not the exhaustive list. We have a full and this is the minimum core items we have to have in any way we do a rehab prescription, and the rest is built around it to ensure that the local and the regional needs are being met appropriately. And what are these? Patient demographics, actions for the GP and the patient. And most of the time, the next care provider may have only little time to focus on that, what they need, what I need to do for this particular patient. A list of relevant injuries and what has been done to that. A management list for each of these injuries. Ongoing rehab needs. Services the patient has been referred to and or need to be referred to. A contact number for advice for the patient or their loved ones. A section where the patient can record their comments. That's an important part as well. Next slide, please. And the rehab prescription should be completed by a healthcare professional after a thorough MDT assessment, signed by a senior staff member, minimum of a trainee in rehab medicine or a consultant in rehab medicine, and minimum should be a trainee in rehab medicine and or a band 7 specialist rehab clinicians. The rehab data set that's collected may be provided to the patient, and there is a question there. It's a may be provided, but I think it should be provided for the patient. But this is not a requirement as of now for the best practice, and it's a discretion of local clinical team depending on the local ability to deliver that. Next slide, please. So what are the benefits? This is my views, and obviously you might differ. And you might have a different views and the patient might have a different views too. I think it's a timely and a full team discharge summary from acute services. Good to have for the receiving side of the clinicians, and the staff who's receiving it will benefit by a detailed summary and know where they're starting, where it's ended and where they have to start. It's good for the team building inside that team to understand, bring all together in the best interest of the patient, and patient being the center of all of us. And it informs and supports the ongoing need for the patient, and it's helpful to the patient where they stand and what they need. Staff, services can be lined up, and we can also figure out what are the services we have and what are the services we don't have. And if I'm a commissioner, if I need to develop a service, it will inform me that what are the areas I could be working with. And it will inform the GP with the detailed actions plans too. Next slide, please. So where are we? And Deirdre already kindly mentioned that she see regularly rehab prescription. Thank you very much for that. And we have regularly doing 100% completion rate. So we started as a paper copy. We developed our own based on a national data set and other things. We developed a paper copy. Now it's all moved to electronic copy. In an essence, sometimes if the electronic version has a problem, then we have a backup paper copy if that's required. But we have 100% completion for several years. 73, so 3 out of 4 patients have completed within 48 hours. As we know, 48 to 72 hours is recommendation. So we try to meet as much as possible. We need to be aware of the acute medical emergency and surgery patients can go to, and the staffing issues can be one of the issues there, barriers there. Rehab prescription, when appropriate, goes to the patient, and on transfer, at transfer it goes to the patient. It may go to the patient, and always at the discharge it goes to the patient. On transfer it goes to the next care provider, and on both transfer and discharge a copy is sent to the GP. So we have, I think, we are hopefully providing what is required for the patient, for alleviating their fears and understanding and supporting them with the ongoing needs and information required for that. Next slide, please. And this is the next slide, please. Specialist rehab prescription, as we said, it is a part of an MDT discharge summary, and we always did a detailed MDT discharge summary, and I think that's another name for it. A specialist rehab prescription comes with a detailed MDT assessment and summary when the discharge happens from the rehab ward. Its idea, in my views, are a fantastic idea. It'll support all the stakeholders involved in the supporting the patient and the patient, obviously. But it can come with the challenges when you're delivering the services, as we all understand it and accept it. Ability to complete from staffing issues, prioritizing clinical needs. If you are short of staff, would you focus on the saving lives or filling a piece of paper? And these are the questions and the issues I face, and I need to look into that as well. And getting the patients and family getting involved in those acute time and seeing that well ahead of the time to see, because their focus maybe is surviving today rather than looking for tomorrow. So that identifying the SMART goals. The SMART means specific, measurable, achievable, realistic timed goals during acute time can be very challenging and can be very daunting, or maybe patients may not be in that right attitude or right mood to participate in those goal setting in the early period. So the goals keep changing. We all, irrespective of whether we have injury or not, our goalposts keep changing with our life, and so is our patients with the critical injury and illness too. And they may not identify the major problems in early time. We have seen it many times. Patients coming with a minor head injury, discharged from A&D or acute units, and they said, "I'm fine, I'll go home." But later on in the coming days, they realize there's a major problem, and I'm not picked up that time. And I'm really not able to myself or what it was before the injury. And there are sometimes you will be hearing that, okay, it's very well said that I need, for example, let's say psychology. I'm not picking on a psychology. Let me say that I want psychology. This patient requires psychology. I know the waiting list is about long waiting list to access psychology. Am I giving a false expectation for the patient? And will the patient be harmed by giving wrong informations by that, or will they be focusing on getting the psychology rather than seeing the other steps, how they can improve themselves? And in some minority of the cases, there might be some sensitive information which may not be applicable to go in a rehab prescription along with the patient. So this is what I see is positive benefits and challenges. Whether it's put on a best use, whether it's helping the patient, if it's helping the patient, how much is helping patient, how that can be improved further, and If it's not helping a patient, why it's not? In spite of all these fantastic ideas and all huge effort to put the staffing ready and the whole NHS coming behind it and making it work, why it's not helping and why it's not doing what it should do? Those are the questions. I think there are a lot of unanswered questions even for many of us, and definitely I will face it all the time. And I would rather ask that the patients and their loved ones to seek their views and correct it if we can. Next slide, please. So one of the national studies I just quoted here. I know this slide is very busy, but there's a national clinical audit done in October 2016, which showed that out of 22 major trauma center, in 2/3 of the center, rehab prescription was not passed on to the patient. I hope it's just October 2016 and things have changed for better by 2022. A Freedom of Information Act information from the CCGs through the UK AVI form also found the response rate is poor, and I'm also hopeful that this is only the response rate of the passing is poor, and they genuinely because of the staffing but they are really copied to the patients and GPs, or if not, they moved on to the next stage, better to the next stage as well. Next slide, please. In an essence, we all agree, I think this is a rehab prescription, which is a interdisciplinary or a multidisciplinary, a team view of the patient and understanding the patient, how they were before and how we can put it back to themselves or as near as possible to that pre-existing or the background functionality as much as possible. And our rehab prescription will inform this decision making or the required services in a nice way. And it's a very valuable tool. It promotes and holistic needs and holistic working, bringing staff together for the patients. It promotes an early and acute rehabilitation and an ongoing rehabilitation. There are 2 pointed: early MDT, acute part of the rehabilitation, and an ongoing provision of rehabilitation. It gives focus to the both. It empowers patients and family and engages them. Obviously, one person who can do the rehabilitation is the patient themselves, and the family could help, and this allows them to empower and engagement to the next level to improve in a rehabilitation. So I think rehab prescription ticks all that boxes. In spite of all the staffing struggle and the COVID pressure, I think we are doing really well. And the last data set I think I have completed, which is our recent outcome data, our recent rehab prescription completion data as well. So we are still doing that. And hopefully this is being done in various other centers across the country. And hopefully that is helping our patients and their loved ones. And happy to listen to you and take your questions too. Next slide, please. My only hope that rehab prescription just not leave it to a trauma only, because any patients who are coming with a severe illness or injury will have a lot of rehabilitation needs. They need a lot of help from a multidisciplinary approach, from specialists, from therapy, from care elements, and all of them need to be addressed. And that just should not just limit to the trauma. As we always do, the specialist rehab prescription or the discharge summary from a rehab units we do for all patients, and the rehab prescription should be there for all critically injured patients. Next slide, please. Thank you, and happy to take your questions.
Well, that's really excellent, Ganesh, and I'm not sure you joined us for Miriam's initial presentation, but that's 2 of you from 2 different fields of expertise saying lots of the same things, really. So you think we might have thought about that. We didn't know that it would tie in so beautifully. We've got lots of questions for you. Some will be quicker than others to answer, I think. The first one. Do clients who are the recipients of virtual appointments feel that they are receiving a high quality service, or would they prefer face-to-face?
Thank you, Deirdre. And I asked this myself, and I'm one of the. I reflect on, obviously, as a service, we reflect on our service. As a clinicians, we reflect on it, and I can say that for sure. Yesterday, my clinic, I had a clinic, and I had a few patients who were on a video clinic, and few are face-to-face. Just like a lawyer, I would say that it depends. It really depends. And I'll give you an example. If patient is coming from Isle of Man, as you know very well, my setting in the Walton Centre, if the patient is coming from North Wales, Anglesey, for example, or Cumbria, or patient coming from Isle of Man, and all they want is some prescription, a suggestion for a medication, or they want to talk to me about it. They want me to liaise and be there, a sort of case manager to help them, to direct them, and just all they want is to talk to me. They will prefer a video call. And there are another patient was in a nursing home who would have been very difficult to come to my clinic in a normal face-to-face setting, and patients could able to talk to me. The staff nurse who was looking after in a nursing home able to talk to me and explain their difficulties and say the way forward, how we could help. And one of those patients needed to come back because I needed to give a Botox injection for them. Then you can target why they are coming and what other needs can be met. In summary, if you choose the right patient, and if they have an offer of video clinic versus a face-to-face, which we do. And as you know, we run a mixture of clinics, and we offer to the patient, for example, if they're having a nerve block or a Botox injections or drooling injections, or if they have to have a physical examination, then the face-to-face is invariably the way to go. But if not, if it is just a follow-up clinic, I think it's not having, it's a carbon neutral to sit in the Isle of Man and talk to me on a video call rather than flying all the way and staying here and unnecessarily causing them fatigue and tiredness.
So a bit of both.
Bit of both. But it should be driven by, not by me offering them, you must come to face-to-face or a video clinic. It should be driven by the patient. What should work with them? What will work for them and what will not work for them?
Okay. Next one is, what is valuable intensive rehabilitation, and when does intensive rehab become too much for neuroplastic change? That's a big question.
Right. And there is no answer for it. I think these words are being used extensively about the intensive rehab, post-acute rehabilitation, and the maintenance physiotherapy or maintenance rehabilitation. What does it mean? This is the questions, and if you go into PubMed or Google Scholar or into educational publication, there's a wide variety of fluctuations in what it means. But in a nutshell, if I have to put it in what is realistically possible, and if you're saying in acute settings, if you have intensive, what comes to my mind is possibly a daily input of physiotherapy, a daily input of occupational therapy. I'm saying working day, so that's a Monday to Friday at the moment, and that's daily physio, occupational therapy, speech therapy, and potentially 3 times the psychology and rehab consultants, and so on and so forth. But it's not for everybody, as you rightly said. There are patients who get extremely fatigued and may not be able to tolerate those type of input. And how will you identify which patient will tolerate and which are not? Again, it depends. Again, I'm not really skiving or not answering your question, but understand by putting that for a challenge. It is like a child, how some children really can absorb a lot more. They go to school, they go to private tuition, they go to any extra classes, they'll do it, and they are able to absorb it and use it for development. Some children will say that this is exhaustive. Either they're not interested or it will actually counterproductive. So just stretching the muscles repeatedly, if the patient's not engaging or not able to engage, it's not helpful. So it
depends on the patient, and we look at them individually and patient-centered. The next one, do you have any experience of rehabilitation and long COVID?
Yes. There are two elements of the long COVID. Obviously, we see patients after in very severe COVID and intensive stay and critical illness neuropathy or COVID neuropathy, and patient going severely having a losing muscle function following the several stays in ITU following COVID. That part of COVID. And second thing, we are talking about a long COVID syndrome, and we are actually discussing with among the COVID pathway, post-COVID or a long COVID syndrome, we have to say that there are different tier. For example, I would say that's a tier 1, tier 2, tier 3, tier 4. I think around tier 4, when the consultant rehab and other teams need to be involved in, and those discussions are still ongoing about setting a specialist clinic here, because the long COVID tier 1, tier 2, tier 3 is already set up and up and running. And whereas tier 4 is about to set up in any time now. In an essence, at present time, they're coming to our normal rehab clinic, but which is not a MDT clinic. So in a way, we are not 100% meeting their needs, but hopefully we will meet the ongoing complex needs after post-COVID or long COVID syndrome.
Well, it's all very new still, isn't it? So clearly the Walton Centre again at the cutting edge in setting that in place. Next question, one of our audience members has a spinal cord injury as a result of a medical condition. They are interested in the efficacy of online virtual resources support for rehab and recovery, please. I think it's repeating what you've said in response to the other, but can you be more specific because of the nature of the injury, perhaps?
I think and I saw the question slightly differently, Deirdre. If you see differently, tell me. I saw that role of technology and a role of use of a new ways of doing rehabilitation. I can say this more dogmatically because I sit as a chair of a national SIGART, that's a specialist interest group in technology in rehabilitation, which we started last year in as a part of British Society of Rehab Medicine, and our focus is to identify, promote research, look into the new ways of using technology, whether we talk about exoskeleton, you talk about virtual rehab, augmented reality, gaming technology, artificial intelligence, all these new ways of unexplored or untapped ways, or maybe the developing evidences where look into that and guide the team. So there are many evidences are coming through, but I cannot recommend anything at the moment because we are looking into that and we are seeing how the NHS can support and how the British Society of Rehab Medicine can promote and help in both service delivery and what are the Class A evidence behind that as well. Deirdre, you're mute. Deirdre, I can't hear you.
Sorry, that links in with what Miriam was saying again about engineering and innovative technological advances. Next question, are social services personnel involved in the rehab prescription? Do patients get a copy and does anybody follow it up? Well, you have covered some of that question, but just about the social services.
Two other elements. One is a social services. A social worker is a part of our MDT. And she sits in our MDT, and yesterday I had a MDT and where she was contributing extremely positively, and we talk on a weekly basis. We discuss each other patients and address those proactively rather than it becomes an issue and address later. The second part of the question is how we follow this up. We follow up in various ways. For example, what I didn't cover is what are the types of outpatient follow-up we have. We have combined neurotrauma clinic where myself and a neuro surgeon and sometimes psychologists sit together and address the see patients in a outpatient setting. We have a specialist nurse, specialist allied health professional run clinic who takes the technically less complexity but more frequent input requirement can be covered by her. And we have also have a neuropsychiatrist who has developed a whole team of neuropsychiatrists now, because we have one neuropsychiatrist, another part-time neuropsychiatrist, and neuropsychiatrist specialist nurses in a Walton Center who runs a specialist clinic as well. Thank you.
Excellent. Right, the final one, because it ties into our next speaker, who's been brave enough to ask. There were plans to extend use of the RP into all trauma centres. Does Ganesh know if there's been any progress on this?
You meant the rehab prescription to all areas of injuries?
Yeah, across the board, and I think it already has been said it should be in all major trauma centres, but whether each and every has followed it up is another question, isn't it, Ganesh? I think.
Yeah, and other things is about the critical care network has already taken it up and looked into all the patients with all sorts of background, not just a trauma, providing with the rehabilitation. And I know a few of my friends and professional and personal friends who are the leads of rehabilitation inside critical care, who provides the long-standing the follow-up and the support for critical care as well.
Right, Ganesh, I could be here all day because there's still questions left, but we will let you go. You're very grateful for you sparing time for us today. So thank you very much. I'm now going to introduce Chloe Haywood, and Chloe is the Executive Director of the United Kingdom Acquired Brain Injury Forum. She helped reinstate the all-party parliamentary group in 2017, and she's in and out of Westminster all the time, fighting for the rights and the rehab and help for people who have a brain injury. So over to you, Chloe.
Thank you, Deirdre. I have to say or confess that I've not been to Westminster for quite some time now. I think I'm not the only one, but the work has continued nonetheless. So just wanted to thank you for inviting me to come and speak today. It's been really interesting to hear from the previous speakers, from Miriam, from Ganesh, from those of you who are sort of on the front line, as it were, sort of trying to make a huge difference to the lives of people with acquired brain injury. And I have to say that it's just always interesting to listen to you, because we need that information to take to our colleagues in Westminster to tell them exactly how it is. Hence my question about the trauma units, because I know there's been a lot of discussion about rolling out the use of rehab prescriptions beyond the major trauma centres where they're mandated and into other areas. And obviously that would be fantastic for those people with brain injuries who don't access the major trauma centres, but nonetheless need that type of documentation to help them on their rehab journey, as Ganesh explained. So thank you for inviting me. I'm going to come from the basis that people don't know anything about UKBIF and don't know anything about our work. So apologies if you do know a little bit about it, but just as background, the UK Acquired Brain Injury Forum is a national charity and a membership organisation. And our remit is to try to raise awareness of acquired brain injury, to provide networking opportunities and educational opportunities for our members and others. As Deirdre explained, we also provide the Secretariat for the All-Party Parliamentary Group for Acquired Brain Injury. And we have a network of regional groups across the United Kingdom. So I know that Ganesh and Deirdre are quite involved in the group for the North West and North Wales. But we do have about 20 groups across the UK, and at the moment most of them are meeting on a remote basis, but still providing opportunities to come and listen to talks and network with local colleagues. So the UK Acquired Brain Injury Forum launched a campaign in around 2016 called Life After Brain Injury, Time for Change. And when we came to have a look at the campaign and to try to establish what we wanted to do, fundamentally, we wanted to focus our quite limited resources on making the biggest impact for people with acquired brain injuries. And so in doing so, what we did was we pulled together groups of experts in particular areas. So we obviously looked at health and social care, and we also looked at education, at sport, and at criminal justice. And the purpose of doing that was really to bring those experts together to talk to MPs and peers about what would really make the biggest difference in those areas for people with brain injuries. So we were taking that information not from ourselves, but really from our membership, from experts that we knew, from leaders in the field, from those who'd identified the issues. And once we'd had those roundtable conversations, we tried to consolidate the key points of that information into this report, which you can see on the screen now. So this report was published by the All-Party Parliamentary Group in 2018, and it lists recommendations in each of those 4 areas that I just previously discussed. And the focus of the work of UKBIF is to try to take those recommendations forward. Can I have the next slide, please, James? Don't think that's it. That's the one. Thank you. So part of the process of this was to re-establish the All-Party Parliamentary Group for Acquired Brain Injury. There had been an APPG for brain injury previously, and the group had sort of gone into a sort of dormant period because it wasn't really working very effectively. So we had a good think about what we wanted the group to do, and we spent a little bit of time looking at MPs and peers and talking to them about their background and that type of thing. And it was at this point that we approached Chris Bryant. Chris, as many of you know, had done quite a lot of work on the sports and concussion side of things. He'd helped to produce a report which was taken to Parliament preceding the APPG relaunch. And so we spoke to Chris about whether he would be interested in chairing the group. He jumped at it, actually, and I have to say that I think we've been very lucky in that Chris has picked up the baton on this and has just run with it and has just used every opportunity to raise awareness of brain injury in Parliament in any which way he can. So I'm very grateful to Chris. So the APPG was re-established with Chris as its chair. We produced the report, and we basically spent quite a bit of time taking part in debates, putting forward Prime Minister's questions, having meetings with ministers from various different departments, running receptions in Westminster, and developing briefings for other members of the APPG. So although Chris is kind of at the helm there, we've got some really committed members of the All-Party Parliamentary Group, and some of you may have come across those. It might even be your particular MPs. So John Hayes has actually sustained a brain injury himself some years ago, and he is one of the vice chairs of the APPG. Liz Twist is another MP who has taken a particular focus on the paediatric side of things. So she's done a lot of work and participated in a lot of the debates which have taken place in Westminster. Peter Kyle, Andy MacDonald, Carolyn Harris, are others who have really kind of helped to support the group. And on the from the House of Lords, we have David Ramsbotham, who chairs our special interest group looking at criminal justice, and Tanny Gray-Thompson, who is just about to take up the helm of the special interest group we have in sport. So there are many others who've participated in a lot of the debates, but we've really got a sort of a key cohort of people who've really sort of been behind us from the outset. So in terms of how the work's progressed since then, I just mentioned that we've got a couple of special interest groups. One of them looks at learning and education. And so what we've done with those groups is sort of taken forward the concepts that we developed for the roundtables, in that we've pulled together academics, clinicians, other charitable organisations who specialise in the area, and put a small group together. We've taken as our objectives the recommendations of the APPG report, and then we've come together to discuss how we can actually take our work forward to fulfil those recommendations. So as an example, the Learning and Education group, we've worked with some NHS clinicians, with the Children's Trust, the Child Brain Injury Trust. We have a couple of academics. We've got a peer on that group. We also have, we're just in the process of developing a group which will oversee that group, and it will be composed of head teachers, SENCOs, and people who are actually kind of working in the profession itself, just to make sure that what we're suggesting actually fits in with practice for them as professionals. So Enables have produced or published a report on for children and young people who are returning to school with a brain injury. We're in the process of producing some resources, some video online resources for NASEN, who are the organisation who represents special educational needs practitioners. And we've got a number of research projects sort of ticking away in the background, you know, just with the foresight that the evidence base is what's needed before we can really make a change. Similarly, the Criminal Justice Acquired Brain Injury Group, which is now quite a large group, is composed of people doing work in this area. So the Disabilities Trust are members of that group. As many of you know, they're doing some really great work on domestic abuse and acquired brain injury. Headway are also doing some training, which they're rolling out within the justice system. We've also got a research project that UKBIF are actually running with the Barrow Cadbury Trust. So it's basically identifying areas within the kind of transitional age group for people within the justice system. So looking at developing training resources, looking at areas which need a bit more focus. So we'll be hoping to bring a little bit more information on that work later in the year. I also mentioned that we're just about to launch this sports group. So many of you may know that Parliament produced a report last year looking at sports and concussion, and UKBIF participated in providing evidence for that report. The government responded to that in December, and so what we're hoping to do with this group is to draw together a joint response to that government response to the report. Obviously, there are lots of people working in different areas within sports and concussion, and they'll all be doing their own thing, but it's just useful to sometimes come together to sort of share ideas and to agree on specific courses of action. Next slide, please. So just coming a bit more up to date then. So last year, very excitingly, Chris Bryant decided to put together an acquired brain injury bill. So this is a private member's bill that is one of those sort of strange things that happens within Parliament, that is partially reliant on a ballot and partially reliant on how much people or your representative talks about it. So just as a timeline, I think if you could go to the next slide, please, James. So the first reading of the bill was in June, and in September, we decided to really pool our efforts with a number of other charities so that we could really maximise this opportunity. So we got together with Headway, the Children's Trust, the Child Brain Injury Trust and the Disabilities Trust, and we decided to together put together a campaign to support this private members bill. And it's worked really well. I'm just so delighted with how this worked. We set up a series of weekly meetings. We set up a website with resources that people could download. We put together a letter to Downing Street as a collaboration, and members from each of those groups took part in an event where the letter was delivered to Downing Street. And the second reading was scheduled for the 3rd of December, but actually PMQ was listed in the week ahead of that, and we're going to show a clip from that film in a moment. So it really precluded the need for that second reading. Next slide, please. So just as part of the campaign, we gathered signatories. We asked our members to lobby their MPs to support the bill. We developed social media content, and we used coordinated messaging. So those are the supporting organisations that took part. As I said, it worked really well, and we really felt that we all had, you know, a limited amount of kind of time that we were able to put towards it. And just by coming together on a weekly basis and agreeing what we were going to do, it just seemed to be a really good thing that worked really well. And I think actually collaboration in this area is key, because although we've got slightly different remits, we're all doing slightly different things. The fundamental thing at the centre of it all is that we're trying to improve outcomes for people with acquired brain injury, trying to make sure that people can access the care and support that they need, and that goes across the board. So we all felt that it was just such a good opportunity for us to get together that it was just worth all of the effort. Next slide, please. So some of you might have seen some of the kind of collateral that we produced. We were quite lucky in the sense that we decided to produce these face masks at quite an enormous expense, and they arrived in Chris Bryant's office the day before wearing of masks was re-mandated. So it was quite nice to sort of see, you know, various of our kind of APPG members walking around wearing the masks. It was good fun. We also produced some badges, stickers, things for social media, backdrops. We produced like little placards like this one on the right hand side. And although, as I mentioned earlier, it's been really difficult for anybody to visit Westminster, Chris Bryant's parliamentary assistant, Natasha Pantelic, spent quite a lot of time getting people to sort of hold the placard, have their photograph taken, list it on social media. So there was quite a lot of talk about the ABI bill, and obviously Chris Bryant and others picked it up and mentioned it at every opportunity in Parliament, as you'd expect. Next slide, please. So this is a photograph of the charities involved in the coalition delivering the letter to Parliament. So we've got Lisa Turan from the Child Brain Injury Trust, Peter McCabe from Headway, Peter Freeman, who is the treasurer of UKBIF. We've got Dalton Lang, who is the chief executive of the Children's Trust, and Irene from the Disabilities Trust. And that's Liz Twist in the front, and we've got a couple of other MPs there with Chris Bryant. So it was a really fantastic photo opportunity. We got quite a lot of media coverage, and obviously all the charities involved, spread the word too. Next slide, please. So the other thing that we decided to do was to ask people to do a short recording of why they were supporting the ABI bill. We've got really good relations with SameU, and just out of pure luck, Amelia Clark was doing some filming on the day that we asked if she would do a short clip. So she did a piece on the ABI bill, which was really nice. And then we've got other chief executives from the different charities there. We've got one of the UKBIF trustees, James Piercy, who did a face-to-camera piece, and Gerard from the Child Brain Injury Trust. So we did it in a kind of coordinated way so that everybody tried to kind of screen or post these on social media during the same week. And that seemed to work really well. It was a really nice thing to do. Next slide, please. So some of the media coverage that we got in the Evening Standard, then some local media coverage, and also some specialist stuff in NR Times. Chris Bryant did a session on LBC. He also did a piece on Radio 4 and BBC Wales, which was coordinated by the Disabilities Trust. So it was a really nice piece of nice pieces of media coverage to accompany what we were doing. So I'm now going to show you, or rather James is going to show you, the parliamentary question which actually precluded the second reading of the bill in Westminster. So on the 24th of November, Chris Bryant posed this question to Boris Johnson. So we're just going to show you now how that happened.
In a few minutes. Nicky's 7-year-old son had 37 seizures a day because of a brain disease he suffered from. He's had surgery now, but it's a struggle every day to get him to stay in school. Nicky, is supporting the acquired brain injury bill because she believes that the government needs to have a cross-departmental strategy for supporting those who've had an acquired brain injury, whether that's rugby players with concussion and dementia, it's women who've been beaten in the head by their partners, it's people who've had brain injuries due to children who've had suffered from carbon monoxide poisoning, soldiers who've been in explosions. I really hope that the government is going to back the acquired brain injury bill. But above all, we need a strategy to help the 1.4 million people in this country. Will you give us that? Prime Minister.
I want to thank the Right Honourable Member for raising this vital issue and for his commitment to this cause, his personal commitment. And I can assure him that we are starting his proposed bill and working to ensure that people do get the support for the acquired brain injuries that they have received. And what we can certainly pledge at this stage to do, and I hope this will be of some use to him and the many who care about this issue in the way that he does, and as I'm sure members do across the House, the Department of Health and Social Care will lead on.
Great, so hopefully you can hear me now. That was obviously a fine day for us after lots of campaigning. There were lots of nods there from Michael Gove and from the Minister. And the next slide, James, here, which came up the next day from Sajid Javid, which was, again, something we were really delighted about, was his confirmation that there would be an acquired brain injury strategy headed by the government. So really delightful news. And Gillian Keegan, as you can see there, has been named as the co-chair alongside Chris Bryant. So fantastic news. We didn't really need the bill any longer, although we all sat through the morning where it was supposed to be discussed, listening to a very lengthy discussion about music licensing. And I think Chris had previously sort of said at the UKBIF summit that one of the shenanigans that takes place in Parliament is that they talk out something which means that they don't then have to discuss the next thing on the agenda. So that's exactly what happened with the bill. But we had our strategy, so we were all quite happy. So next slide, please. So this is Chris Bryant and Gillian Keegan, who met a couple of weeks ago to start discussions about the ABI strategy. And that meeting went very well. They've appointed a lead official from the Department for Health and Social Care, who is going to kind of lead the panel. In fact, that panel, or programme board as they're calling it, have got their first meeting today, where they will be agreeing the parameters of the work. But obviously officials are going to be recruited from other government departments. And I think, as Miriam mentioned earlier, this is not something that's confined to health and social care. And as we know from our report and from our discussions, brain injury affects people in many different parts of their life. And so that's why it's key to make sure that it's something that works across government. So the plan with the strategy is that they're going to have some sort of a launch before Easter, and the next stage is to send out a call for evidence, which will take place in April. So at the moment, we don't really know any more detail about that call for evidence, other than it will be quite wide-ranging. It will include opportunities for people with a lived experience to participate, so it won't just be published research. So, but obviously all of you who are publishing research or gathering data, you know, this is a really key moment to make sure that that information is sent in to the lead officials, to the programme board, so that they can take it into account when they're producing their strategy. Next slide, please. So this is my final slide. In terms of our charity coalition, we're continuing to work together. We're just in the process of setting up a new website. So it's changed from ABI Build to abistrategy.org.uk. And so by looking at that website, it will just keep you up to date with how things are progressing. So what can you do? As I said, keep an eye on the website, submit your evidence when the call for evidence comes out. I would keep in touch with MPs as well. I think we need to kind of keep the pressure on to make sure that those questions are being asked, you know, that when the programme board publishes its action plan, that we're making sure that we're happy with it. And I suppose the final thing I would say to those of you who are not already members of UKBIF, please join us. By joining us, we can keep in touch with you and make sure that we keep you informed about what's happening with our campaigns, but also with our events and regional groups and other pieces of work. And it helps us because we can then use the information that you provide to us from your frontline work or from your lived experience or from other sort of pieces of work that you're doing in life that can help us to make sure the information that we provide to MPs and the APPG is as coherent and as possible. So please do join us, and thank you all for listening.
And thank you, Chloe. I wasn't expecting to see Boris feature in our conference.
Sorry about
At
that.
least he was doing some real work on that day. That makes a change, doesn't it? We've got one question for you. How do you make patients and relatives admitted to hospitals with ABI aware of the presence of UKBIF and the resources available?
Yeah, that's a really good question. I mean, I think that it's been one of those difficult things, kind of letting people know about what we're doing. And I think that when people are in hospital, it's easy to be a bit overwhelmed with information, or to perhaps not have all the information that you need at the right time. So there are organisations like the Children's Trust who have coordinators within hospital, and very often they or other professionals who are kind of working in the hospital arena will, you know, suggest UKBIF to patients and relatives. We do have membership for people with acquired brain injuries and carers, but I would say that predominantly the membership is for professionals working in the field, and obviously people like Headway are there to provide more sort of frontline support for people with brain injuries and their carers who are at that point when they're in hospital.
Great. Well, we're going to have a short break now, a bit longer than the last one, which I think ended up being 3 minutes. Just enough time, hopefully, for you to dash downstairs and get a sandwich before we listen to 4 more speakers this afternoon, all talking about rehab in action. So we've talked a lot about research, about cutting edge, about developments this morning, and we're going to continue with that, but see it in action with some of our clients and some of our lawyers who work with the clients. So Chloe's done you a massive favour because she's finished early, so she's got us back on time. So it's 12:43 now. If everybody can come back at 1 o'clock, then Natasha, my colleague, will introduce the next stage. It's not the afternoon, so don't put your feet up, don't have any sugar, just have something very quick to keep you alert, and we'll be back at 1 o'clock.
Welcome back, everybody. Thank you for joining us for our final part of this rehabilitation conference. We have some more amazing speakers coming up, but before I hand over to my colleague Glenn, can I ask you to complete the feedback survey, which should be in the Q&A box on your screen now or at the end of the conference, but please do fill it out because it really helps us plan our future events. So over to you, Glenn.
Thank you, Natasha. Good afternoon and welcome back again. I hope you're enjoying the conference so far. It really is great to have so many here today to explore how we might rethink rehabilitation. We've heard some great presentations so far and some really exciting developments. As you can see on the slide, my name's Glenn Whitehead. I'm a solicitor in the serious injury team here in Sheffield. As a former physiotherapist, rehabilitation is a real passion for me, and I've no doubt it's the same for all of you too. It's my pleasure to welcome Heather McClellan, who joins me today. Heather's over 25 years experience as a physiotherapist in occupational health and also in rehabilitation for orthopaedic and musculoskeletal pain. Heather has worked in the NHS, engineering industry and private practice. She's also designed a national occupational health physiotherapy service. Over the past 20 years, she's lectured extensively on rehabilitation and the topic of return to work after injury, and furthermore, she's won awards in this area. And Heather is here today as the founder and director of Design to Move, which is a specialist functional rehabilitation provider who I approached to help with my client. Next slide, please. So it goes without saying that everyone here today is committed to providing high quality rehabilitation for our clients, and whether that's legally representing them or as a clinician appointed to provide the treatment, we all have a view of what good rehabilitation looks like. In order to ensure treatment remains evidence-based, we seek out training opportunities and develop our understanding of what options and modalities are out there. And after all, if you're not aware of an approach and don't have it in your toolbox, then it can't be made available to your clients. Once you have your tools, there are further factors which will have an impact on what treatments are selected, when and how they're delivered. And creating that perfect mix doesn't simply fall into place. It relies upon good insight, understanding and effective communication. Our case study today provides an example of where my client's circumstances prompted us to look at the bigger picture when considering his treatment. I'll include a caveat here. Of course, standard clinic-based model may still be appropriate for many clients. On this occasion, we went for an approach which might not be suited for every case, but it was perfect for this client. And hopefully our case study will provide you with another tool in the box when it comes to creating the right blend for your clients. Next slide, please. So as a background to this case study, I wanted to flag this piece of research. This paper was originally published online in 2019 and later published in the Journal of Sports Medicine in 2020. I appreciate this arrived after or a little later than the treatment started in our case study, but in reading the paper, it was encouraging to see that the approach we selected contained all the elements which were later agreed to be good practice. I also accept that this paper doesn't fully represent a typical complex injury client group. The treatments reviewed were all purely musculoskeletal and took place in an initial contact setting. It's worth noting that there was an international study. It did take results from all over the world, and as Miriam mentioned earlier, there's an emerging global approach to rethinking rehabilitation. Now, I'm not aware of any similar research that has analysed a mix of neuro and musculoskeletal groups, so for now I find this paper helpful as it does recognise that symptoms experienced in a musculoskeletal conditions can share common features, and therefore it may be possible to draw on some overarching recommendations. Now, I don't want to go into the paper in fine detail. The reference is there for you if you want to read it. In short, the study was a systematic review of treatment for spinal, knee and shoulder pain, and it looked at common clinical practice guidelines for treating each of these areas. They took a large pot of responses and distilled them down to draw out the agreed traits of consistent recommendations for the treatment of musculoskeletal pain. In the paper, there's a table and that provides a summary of the findings. There were 11 consistent recommendations. Some were musculoskeletal specific, but most are easily transferable and can be used when we're considering treatments for our client group who have multiple injuries. I'll give you a second just to run through those 7 recommendations on the slide. Now, it may be that a quick run through these 7 points present a formula that appears pretty familiar to you, and it may even appear obvious, which is fabulous, and that just simply means that we're all on the same page. And what I wanted to do today is show you how taking this approach provided a great income for my client. Next slide, please. So let me introduce EB. He was a 31-year-old male. He was married, one young daughter, and soon to have a second on the way. And this presented a busy household, obvious demands on his time. EB smoked, but was otherwise fit and well. He was active with a range of hobbies. He played football, enjoyed walks out with the family, darts, pool. He had a keen interest in motorcycles and was a motorcycle mechanic by trade, carrying out insurance assessments and repairs. And his work involved both manual and technical components. He did know the job well. He'd worked for the same local business for about 4 years. Now, the index incident occurred when EB was at a motorcycle racing event. He was watching the race from a designated spectator area. A bike left the track at high speed, smashed through the fencing and collided with EB. Next slide, please. So EB sustained a head injury, a large laceration from the impact to the motorcycle. He also sustained lower limb fractures, a segmental open fracture of his right distal tibia and proximal and distal fractures of his fibula. He was taken straight to the trauma centre and found to be clear on CT head. A later neurological expert assessment provided a diagnosis of subtle closed brain injury with a combination of focal and diffuse axonal injury. His orthopaedic injuries were corrected with an IM tibial nail and a plate and screws to his distal fibula. He did return to surgery 5 months later for a further procedure to remove the diastasis screw in his ankle. On assessment of his psychological injuries, he was diagnosed with post-concussive syndrome and PTSD. He presented with cognitive impact, word-finding difficulties, raised anxiety, and executive dysfunction. And this kind of presentation we often see is described as walking wounded. And if you asked EB, he'd have said that his primary treatment needs were related to his leg injuries. But for us and the team, it was clear that the needs arising from his other injuries would need to be taken into account when considering the final approach to treatment. Next slide, please. So in addition to the factors mentioned on the earlier slide, there were other elements to consider when considering the blend of his treatment. Fortunately, liability was admitted early. We'd completed a rehabilitation checklist and had started to discuss treatment options with EB. An immediate needs assessment was completed, which recommended case management, private orthopaedic input, physiotherapy, occupational therapy, a rehabilitation assistant, and a support worker to encourage access to the community. The defendant wouldn't confirm agreement with the INA recommendations, but he did offer a modest interim payment rather than provide funding under the Rehabilitation Code. So when we chatted through with EB what he wanted from rehab, he was motivated to engage with physiotherapy. He wasn't particularly keen to attend a gym type environment. He had a busy household, which made sessions in the home difficult. He was having difficulty sleeping and reported being very tired at times. He also reported issues and concerns about the union of his fractures. Despite this, he continued to smoke, even though he knew this was detrimental. So I discussed treatment options with EB and his case manager. There wasn't sufficient funds to introduce all the proposed support at once. It was difficult to give a green light for a range of treatments which ran week to week. Our funding flow was slow, it was sporadic, it was uncertain, just simply wouldn't permit that. We proceeded with the case manager and a psychologist on a unilateral basis, and when considering therapy and having seen functional rehabilitation work with another client, it appeared to be the perfect fit for EB. And now Heather will introduce how a functional rehabilitation programme works and how it was implemented with EB. Thank you, Heather.
Thank you, Glenn. That's great. So thank you, James, also for forwarding the slides. So at Design to Move, we have 7 key principles that we work for functional rehabilitation, which you can see on the left-hand side of the slide here. These are based on clinical evidence from a variety of sources over the years, but which have been confirmed by the Lynn et article that Glenn just mentioned. So why was this most appropriate and a good fit for client EB? Well, based on the evidence, we knew that his musculoskeletal and orthopaedic injuries were likely to respond well to this functional approach. We also knew that he had a high risk of long-term disability, chronic pain and future work loss based on the complexity of his injuries, his personal situation and the psychosocial screening. So therefore, if a standard approach had been tried and was not effective, critical recovery time could have been lost, which could have had an adverse impact on his outcome. We were also able to measure progress and functional improvement throughout the programme using the patient-reported outcomes and functional measures. And the goal setting enable us to link the rehab programme directly with the client's needs, his family life and the anticipated work demands. Now, in addition to that, we have a community-based delivery model that enabled us to provide a service that was flexible and suited the family situation. It used home sometimes and local facilities other times. Our detailed reports include all the baseline outcome measure data and therefore enables an objective review of progress at reassessment and discharge points. And our fixed fee and clear start dates with an anticipated end date of the programme gives that predictability and enabled the client, the referrer and the funders to plan ahead. Next slide, please. Thank you. So what's involved? Well, the first thing that we do is a functional rehabilitation assessment. And so this aims to establish suitability for using a functional rehabilitation programme and to collect that baseline clinical data. All of our assessments are either physiotherapy or occupational therapy led, and in this case was physiotherapy led. And from this list of components that you can see here for functional rehab assessment, the first three should be very familiar to you and should be included in any good quality clinical assessment. The items in purple are the additional components that we include in all of our rehabilitation assessments. So patient reported outcome measures, the functional testing, which is tailored to the needs of the client, identifying the work tasks and demands where that's appropriate to do so, and the goal setting. And very importantly, we do have the discussion with the client about what's involved in the programme and if they still want to go ahead and participate. The output from this is a detailed report, which includes all the clinical data and the recommendations for the rehabilitation. Next slide, please. And next one, please. Thank you. So once the assessment and report are completed, the functional rehab programme can begin, and our clients usually have between 1 and 3 phases of rehabilitation, and in this case EB had all 3 phases. So in our phase 1 we talk about being rebuild and foundations for movement. So for EB this phase took 5 months and we focused on ankle and knee mobility, back pain management, confidence in weight bearing, and you can see the playground equipment at the top right to just try and make that a little bit more fun. Walking to improve fitness using a pedometer and a graded walking program. And then we also include contribution to sleep management and reinforcement of the stop smoking messages to support the bone healing. Next slide. Thank you, that's great. So there was a gap of 3 months between phase 1 ending and phase 2 starting due to the funding that Glenn's already mentioned. And then the phase 2 and 3 were combined, and that took 9 months. So these phases focus on fine-tuning the movement and the function for the client's specific needs, aiming for an independence from therapy. That looks like an integration back into normal physical activity and back into work where appropriate. For EB, this also included an assessment of physiological data, that's heart rate variability, and that's the graph you can see at the bottom of the slide there, which I sadly haven't got time to go into the details, but that's enabled us to give feedback and support around managing the days when the client just was feeling unmotivated to do his home rehab and his physical activity. And then alongside that, the functional activity was progressed. So we went, from walking to a running program. We took indoor home activities out into outdoor activities such as gardening. There was also a change of work goals between the phases, and that led to us needing to ensure that a broad range of practical capabilities were addressed, such as kneeling and squatting tolerance and basic lifting capabilities and confidence. Next slide, please. Thank you. And the final part of any Design to Move functional rehabilitation programme is the final reassessment. We review all the patient reported outcome measures, the functional testing and the goal setting from the initial assessment. In some cases, such as EBs, where there's more than one phase of rehabilitation, there is also a review of reassessment points within the programme. So a detailed report is produced from this, which includes all the data, comparison with the original results, graphs, interpretation of the results where appropriate, and any further recommendations for rehab. So for client EB, his total rehabilitation programme length was 17 months. And as you can see, there's an example on the slide from the programme of some of his results. The table there shows the patient reported outcome measures, just a few of the ones that we used. So the first column is the names of some of those, which some of you may be familiar with. The second column is the results from the initial assessment. The third column is the results from his midway assessment, and the fourth column is his final reassessment results. And the last column there shows the change in results from start to finish, and all of those demonstrate significant clinical improvements. So our report would include all that data, and it would include an appendix which explains each of those measures and how to interpret the results. And the graph there is an example of the ones that we use in our reports. It shows the results of the Musculoskeletal Psychosocial Screening Questionnaire. It's always a good one to say. The first three blocks on the left show the maximum score, and then the moderate risk and high risk cutoff points. Now this is risk of long-term disability, chronic pain and future work loss. The 4 blocks to the right are EB's results over time, and what you can see at a glance here is that his risk came down from high to moderate to low during the 17-month period of his rehab programme. And the next slide, please. Thank you. So lastly, I'd like to share with you what our client told us. So we followed up with him in 2021, which was about 12 months after his programme with us ended, and show you how he got on with his personal goal setting. So I'm going to read out the testimonial that feedback he gave us here. I'm in a good place. I'm working hard around the house with the chores, whilst my wife is homeschooling our 6-year-old daughter, and our baby is 2 and goes to nursery part-time 2 mornings a week. We're working well as a team. I'm back at work, working in a maintenance role. I'm finding it easy to do the tasks required. I'm really enjoying it, and I'm working part-time 2 to 3 days per week. The graph on the right is the results of his goal setting. So we use the patient-specific functional scale, which ranks the ability to meet the goal 0 to 10, with 0 being unable to do it, 10 being able to do it. So where there's no blue bar, this is because at the first initial assessment, he gave himself a 0 out of 10 for that goal. And the best way to do is to convert this into a percentage. So if we think about the percentage, at the assessment, EB was only achieving 10% of the goals he'd set himself. At his midway assessment, 5 months after phase 1, he'd achieved 65% of his goals. And at the reassessment, at the end of all the phases, 17 months later, he had achieved 96% of his original goals, which I'm sure you'll agree is a great outcome. So thank you for letting me share just a small part of EB's clinical journey with you today. I hope you found it interesting, and I'll hand back over to Glenn.
Thanks, Heather. Next slide, please, James. So aside of the fantastic feedback we received and also Heather received, it was helpful for us to sit back and reflect on why this treatment approach had worked so well for EB. And I came up with the following points. As Heather said, there was a thorough assessment, and this allowed us to drill down to what the client really wanted for his treatment and encouraged a real investment for him in his recovery journey. He felt that the team was working towards his recovery rather than something that was simply being done to him. And Ganesh spoke earlier about the importance of this engagement and how it is promotes and improves the recovery journey. The initial assessment and the first beat data identified a number of factors which would impact upon EB's recovery, both injury related, general physiology, and also his wider home life. We were able to tie these in with EB's other therapies, such as his psychology sessions. He received a clear home programme that was communicated well. He recognised his psychological injuries, and the programme focused on his return to work. From a financial perspective, the certainty presented by the use of a block package fitted with the funding challenges that we were facing. The approach provided clear reports and strong evidence, so we could return to the defendant to request further funding. It's worth mentioning that the block therapy fees were agreed in full in the defendant's counter schedule of loss. And finally, with hindsight, the approach hit all the markers previously mentioned in the Lin et al. Research paper that I pulled up earlier on. And this is really reassuring for us, and to know that we're doing the right thing going forwards. Now, I know also that Heather was also able to reflect on the service. So next slide, James, please, and Heather will run you through those.
Thank you. So just a summary really of some key questions, which may again seem obvious, but just things to consider when choosing a rehabilitation service or what service to recommend for a client. I think most importantly always, does this service basically meet your client's clinical needs? Are you in the right place? What's the most practical delivery in order to maximise the likelihood of a good outcome? So, for example, community-based or residential or outpatients, or even a combination of all of the above. And then thirdly, would a functional rehabilitation approach support your client to reach their goals whilst also providing you with the evidence of progress and outcomes achieved? We have a couple of Design to Move resources that you might find helpful if you'd like some more information. The first one is more on our 7 key principles of effective functional rehabilitation, and the second one a bit more information on when to choose standard care or functional rehabilitation. If you'd like either of these or both of them, please do email us on info@designtomove.co.uk, and if you're a therapist interested in finding out more about how we work or possibly working with us, please also get in touch because we'd love to hear from you. Thank you very much.
Great. Next slide, please, James, which is just really a thank you to you all for listening. We hope you found our case study helpful. It provides some food for thought for the next time you're considering treatment options for your clients. Now we've got very limited time for questions, but I'll take one that's just popped up on the chat. And this question was a specialist rehabilitation medicine consultant involved in the management? If not, did you consider it necessary? Really, all I want to say there is our selection of treatment and blending of the programme is always underpinned by what expert evidence we have going on in the background, and I haven't drawn on those or explained those fully in this presentation today. With regards to the actual blending of the treatment from the case management's perspective, we didn't include a rehabilitation consultant in that process, but obviously everything that we decided on between us as a group was based upon the evidence recommendations. Okay, so if that's everything for us, thank you very much again. I'll pass you over to my colleague Anne, who's a partner in the medical negligence team. Thank you, Anne.
Thanks very much, Glenn, and good afternoon, everyone. I'm going to speak to you this afternoon about rehabilitation in the context of my work, which is with clients who are claiming that their injuries arose as a result of medical negligence. I hope to give you a flavour of the variety of clients we see, spanning all ages and across many different injury types. One thing they all have in common, though, is the desire to return to as normal a life as possible. And within this presentation, I hope to share with you the challenges we face in supporting those clients with that, as well as sharing a video from one of my clients who is an inspiring example of where we've made a difference despite those challenges. Next slide, please. So the challenges, by definition, if someone is claiming medical negligence, very often they've already sought medical treatment or advice because of an existing condition. And somewhere in their care pathway, something's gone wrong and they're now worse off as a result. I should say it's not always the case that the condition is problematic. For instance, many of my clients are children who have suffered a brain injury as a result of negligent management of their birth. Their parents very often suffer from psychological trauma too, and they also need rehabilitation to learn to live a different life to the one they might have imagined. All of this makes our cases complex in terms of client care, as well as challenging in a legal sense. And another feature of my work is that very often clients come to us quite late after their injury. A significant period of time might have passed, and the window of opportunity to achieve the optimum outcome in terms of rehab may already have been lost, but that doesn't mean that we don't try. Sorry, double negative there. Or sometimes they've had a reasonable level of rehabilitation in the early period, for example, with a spinal cord injury, but then they seem to have been left to the mercies of local services after that and have lost conditioning and momentum as a result, something which Ganesh spoke about earlier. In relation to child brain injury cases, parents are often overwhelmed in those early years and quite understandably delay investigating claim until their child has at least reached school. The challenges in those cases are often around the adequacy, for example, of an education, health and care plan, EHCP, and the actual delivery of that plan, which all too often in our experience represents the minimum acceptable. And having said all of that, my experience is that it's never too late to make a difference to someone's life with the right intervention and support. And interestingly, in relation to Dr. Akiri's presentation earlier on the use of cannabis, one of my child brain injured clients currently has been prescribed cannabidiol for her intractable epilepsy through the Sapphire Clinic in London, which of course is a private prescription, but that prescription is supported by our litigation paediatric neurology expert, and it is beginning to make a difference. Finally, a big challenge is of course related to funding, where liability is disputed, because in medical negligence cases, very often our experience is, unlike other personal injury claims, the serious injury rehab code doesn't apply. And that means that in those cases where we don't yet have a resolution to liability, we don't have access to funding. So we have to be creative and think of other ways to support our clients' rehabilitation. Next slide, please. So the IM approach, the Owen Mitchell approach, is that we are proactive. And where we can, we challenge the defendant to engage in early dispute resolution with a view to securing that interim funding as early as possible. That's particularly effective in baby brain injury or cerebral palsy cases, in my experience. And once an interim payment is agreed or in place, we can then introduce and roll out case management and a range of rehabilitation measures, much of which you'll be familiar with. Before that, we support our clients where we can by seeking the optimum statutory provision where possible. We engage with our charity partners also, and we have many, many charities, local and national, across the country. And where possible, we try to access free sessions. For example, here in London, some of our clients are able to access free sessions with the Bobath Centre. Finally, where it's clear from the outset that liability is robustly denied, we deal with that as a preliminary issue in the litigation. So we get that out of the way first so that we can secure interim payment of damages and then get on to full quantification, but that happens alongside rehabilitation. Next slide, please. So my case study is around my client Justine. We're still dealing with liability in Justine's case, so I'm being cautious in the details I can share. But in many ways, as an adult client with capacity, her case is typical in that she came to us quite late, that is close to the 3-year limitation period for issue court proceedings, not least because she was still receiving active treatment up to and indeed after she instructed us. And her story is both tragic on the one hand, but also, I think, inspiring. So she was 19 at the time of her injury, and she had just come to the end of Freshers' Week at uni. There was, not unusually, a Freshers' flu going around. So when she felt unwell, her friends weren't initially concerned, but over the course of 2 days, she deteriorated rapidly to the point where her friends in halls called an ambulance. The paramedics weren't particularly impressed, shall we say. Not that they thought she was trying it on, but they didn't rush, they didn't treat it as an emergency. And there was a further significant delay in recognising sepsis when she did arrive at A&E, and a further delay in initiating the sepsis protocol, so that by the time she was finally given IV antibiotics, the evidence is that tissue necrosis had developed in her lower legs. She went on, she developed and was diagnosed with meningitis and had a very long illness, ultimately requiring bilateral below-knee amputations. You'll see her in the video shortly, and in many ways, I think she's made a remarkable recovery, and she's a very impressive young woman. Her recovery is particularly impressive because of the severity of her illness and the fact that she doesn't have any cognitive deficits. She was at university away from London at the time, and after she returned back to London, she received some rehabilitation as an outpatient from a local unit, and her care in relation to her amputations was transferred to a local team. There were some ongoing issues with stump healing, But at the time she instructed us, almost 3 years on, she still hadn't received colour-matched prosthesis. And this was enormously important to her, quite understandably. But when we first met, aside from her concern about the treatment provided to her, which led to her contacting us, and the devastating consequences of that for her, her focus was on getting back to university and some sort of normal life. And understandably, for a young woman of her age, she wanted her prosthetic legs to match her skin colour. Over a 6-month period, Sharon Williams, our support and rehabilitation coordinator in London, supported Justine by engaging with her prosthetics expert and a clinical team. Our public law colleagues became involved and they considered this to be a human rights issue. And following intervention from them, Justine was finally provided with prostheses which matched her skin colour, and she has now returned to university, albeit, you know, a little later than she had hoped. So, James, if you can play the video, please.
Hello, my name is Justine and I'm going to briefly be speaking to you about my experience at rehabilitation after undergoing a double below knee amputation. At first, the experience was very positive. I was going to the gym every single day, learning how to walk on prosthetics and getting fit enough to actually walk on them. I expressed to the team I would like legs that look as real as possible, as this was my preference as a new amputee. They then said, of course, and I got my first pair of legs and they were nothing like what I expected. They were these big, really bulky legs, shapeless legs that were white, the colour of a white person's leg. They would put these really dark brown tights on the bottom where it would fall off and actually expose the metal of the leg. And then they would put these white coloured tights that made it look like a white person's leg, and it was nothing like, it was nowhere near my skin tone, and I was very upset and troubled by this. And they then said to wait for your residual limb to shrink a little bit more so it can have its final form, and we'll give you new legs. I then went back to get new legs after waiting a few months and getting used to walking again. And they said to me, and they gave me these new legs, and again they were white, they were these tights, and they were these tights that would get holes that would fall down and expose the metal. And this was ongoing for nearly under 2 years. And my mum called the team and asked them why nothing has changed. It's been 2 years now, and they said to my mum, why can't she just wear tights or wear trousers to hide her legs? No one will know she's an amputee. And that was the last straw, I think. And it was, I was so upset, and I felt so discriminated and so let down by the team. I didn't feel heard or understood at all. And that's when Mum introduced me to the Owen Mitchell team. As soon as I started to receive support from the Owen Mitchell team, everything changed. I was getting support that blew me away, really. I'd be in contact with them all the time, and they would make sure that I was listened to, and I felt so heard, and I felt people actually understood and cared for me, and I'm so grateful for that. Now I have legs that are very close to my skin colour. They are thin legs that look really real, and legs I've always wanted after becoming an amputee. I'm so grateful to the team. I received constant care, constant support from the team, and that's why I'm where I am today. I'm going to university, studying graphic design, and I have legs that I'm so proud of and happy with. Now I know I have the team's support. I don't feel like me and my mum have to fight these battles alone. I feel like we have constant support, and I feel confident in my journey of being an amputee. Now I have Owen Mitchell by my side. Thank you so much for all your help.
So there she is. I think she's completely inspiring. She's a lovely young person. Doesn't have unrealistic expectations. She understands that her claim is not necessarily straightforward, although we believe that we will succeed with it. And we all appreciate the pressure the NHS is under, but it was disappointing that her clinical team were initially so unwilling to deal with a request for colour matching in a serious way. beyond offering her just dark tights or wear trousers until we intervened. And so it's great to hear from her now that, you know, she's back at university, feels much better in herself. And I can tell just from my conversations with her and Teams calls with her that that little video she made, her expression is lighter somehow. She feels more herself again. Our work on behalf of Justine's medical negligence claim, as I said, continues, but it is great to see her getting on with her life in the meantime, and I would add my thanks to hers for the support she received from Sharon Williams, as I say, our support and rehabilitation coordinator in London, as well as my public law colleagues. Thank you, everyone. And now I believe it's time to pass on to Ruth.
Thank you, Anne. Good afternoon, everyone. I'm Ruth Johnson. I'm a solicitor at Irwin Mitchell, and I'm based down on the South Coast. I'm going to spend the next 15 minutes chatting alongside Lisa Brown, who is a case manager at Coastal Case Management. They provide case management services to injured individuals, coordinating their rehab alongside the civil claim process, which is where I act on behalf of people that have been injured in a variety of accidents. Lisa and I have worked together before the pandemic, but what we wanted to share with you this afternoon is our experience and learning of one of our clients' rehabilitation journeys during the very early days of the pandemic itself. Our client, Mr. X, we've anonymised him for confidentiality, was injured in March 2020, so right as lockdown came in. It was a road traffic accident and he sustained a traumatic lower limb amputation. Initially, when I was instructed, it was the family of Mr. X that contacted me by phone. We were in complete lockdown, as I said, and we had to use phone and video for me to be able to take those initial instructions. Nobody sadly had been able to visit Mr. X. The family didn't know a lot about what had happened. Really, they just knew the basics. He had had an accident, he had had an amputation. He'd also tested positive for COVID, and they were told that the clinicians had concerns over his memory and also capacity. So they were understandably very worried, felt very at sea. And when I took that initial call, what I knew that we needed to do was quickly get case manager on board to understand what was happening, to get a handle on the capacity issues, and to look at how we could support the injured person going forward. Pre-pandemic, a lot of that I could have done by visiting Mr. X himself in hospital, speaking to the clinicians, gathering some information before instructing Lisa, so I had a clearer picture. But as I said, none of that was possible. We also knew that people were being discharged from hospital quite quickly. The partner of Mr. X was also clinically vulnerable, and there was a real desire for them to be reunited as well as looking at rehabilitation. So Lisa, I don't know, do you remember taking that first call from me? And I don't know if you can explain the steps that you took initially.
Yes, thanks, Ruth. I mean, I think, yes, the phone call will stick in my mind. It was really at the very beginning of lockdown, and people were just getting to grips with how we're going to cope with rehabilitation, during that time. And I think the first thing we did, we heard the case, and Ruth explained the details, and for me, the heartbreaking thing was that this was an elderly gentleman that had sustained an injury and contracted COVID. There was lots of fear. So the first thing, obviously, contacting the family to get their sort of story, and then speaking to the hospital, which the family have been very unsuccessful in being able to obtain any information. We quickly decided to gather as much information as we could by speaking to the teams, and I have to say it was really helpful that we were able to get an iPad into our client, and the hospital teams were able to speak to us via Microsoft Teams, which was really, really useful. I think in the beginning, the most important thing for me was to try and explain and get the message across to the hospital that prior to this injury, my client had absolutely no history of any mental capacity issues. And so I needed to understand from a medico-legal perspective whether or not my client had sustained a brain injury or what was going on. It was very clear that she was discharged very quickly due to the COVID, policies at the time. So she was from an acute hospital where she'd been in ITU, gone to the rehab ward for a very short period of time, and then she was shipped across to a stroke ward where the teams, whilst they were absolutely lovely, they had absolutely no understanding really on even how to rehab somebody following an amputee. So we quickly got to work and spoke to the doctors, and one of the first things I asked for, given her past medical history, because we did have some history from her GP, was that she was suffering from chronic UTIs, and one would have imagined that a very basic test would have been done, but actually we asked for her to have her urine sampled at the time, and yes, can you believe she had a raging UTI, a couple of days on nitrofurantoin, and her mental capacity completely changed from them saying that she lacked any capacity at all, and that her rehab potential was poor. And once she was on her nitrofurantoin, she came back and she was chatting away to me on her iPad, or he was chatting away to me, sorry, on his iPad, and it was absolutely lovely to see. So I think the initial INA was really pulling together everything from those medical records and speaking to the family and the family GP, which was really, really helpful at the time. So yeah, it was how we were going to coordinate everything with somebody that had COVID, knowing that the desire was to get her out of that hospital as soon as possible, both from the hospital perspective, but also from the family perspective. And so we had to very quickly start to engage with statutory services because their property wasn't going to be suitable. So I think, that from our point of view, it was looking at the bigger picture as to how we could get these people back together and what her medical needs were going to be. So over to you, Ruth.
Yeah, if I pick up from there, Lisa, because I think the concern over the discharge was the immediate thing that we had to look to deal with, and I think it was probably twofold: looking at the right setting for rehab, but also wanting to place Mr. X and his partner back together with the COVID risks that were around at the time when we were in April 2020. I should add that we knew that the property that Mr. X lived in pre-accident wasn't suitable. Going home wasn't an option. And although we had funding for Lisa under the rehab code, there were no funds available for rehab generally at that point. The accident circumstances were unclear. We're in a few weeks into instruction. So I asked Lisa to look at what could we do, what were the options for discharge from the hospital, so that we could look to seek funding where we could. Lisa, I don't know if you want to pick up.
Yeah, I think that was. Yeah, thank you, Ruth. I think the difficulty there was that it was new for everybody, and even our statutory experts, to be honest with you, were struggling to know, what we were going to be doing. And I think for me, I said, look, let's get a specialist on board to help and see whether or not we can get some funding for alternative accommodation. And what we did actually was we did involve the CCG with respect to accommodation, and we were able to take photographs, or the family took photographs of the property for us, which we then embedded into a document sent off to the CCG. And as I say, Sue Peters, who is a statutory specialist, she was involved in the early stages because she knew that, you know, that the client really did not want to go to a nursing home, and they were very clear that a nursing home was going to be the only option for her unless something could be funded, because it was unlikely that the CCG would be funding anything. So I think we tried to go for a hybrid approach really, and we looked at, well, okay, what can you give us, and what, you know, how much will you pay? And I think that the CCG agreed that they would pay for her care initially, but that obviously the accommodation, they would pay for nursing accommodation. And we had actually found, you know, some accommodation that would have been suitable. However, finding accommodation for two, it just meant that the cost was just not you know, going to be suitable. So as a couple wanting to live together, and let's face it, they were in their later part of their lives, they didn't want to be separated, and a nursing home just not an option for the family, because Mrs. X, the partner, had vulnerabilities in terms of their own health, and you know, they had to isolate from you know, COVID, and going into a nursing home, it was the family's biggest fear that they would just both die in a nursing home with no visitors. So we really did have to get to work quite hard, and we did find, as I say, a placement in Bramshot Grange, which did also offer rehabilitation. However, again, we looked at the costs of that, and we at CCM have a partnership with DGC, which is a company that have some transitional units, and that unit at £1,000 a week was significantly cheaper than the £3,000 a week for the nursing home for the couple. So we managed to get an agreement that he would come to Still Waters, where they were very close to Portsmouth's reablement, so we were able to then sort out statutory provision really easily from Portsmouth hospitals. So from everything to, she was out of area, registering with the GP was a challenge. I remember she wanted to stick with her old GP. So there were lots of things that we had to do, as you would expect with anybody following you know, that type of injury, but particularly difficult during lockdown because everything was done electronically and via Zoom. So yeah, so wheelchair accessible properties are always a challenge, and finding somewhere that can take two people and a support worker was also a challenge, but we were able to find accommodation for our couple to go into, which was very reassuring for the family and for Ruth.
Yes, no, it was. I think on this one we had a really good interplay between statutory services and private funding that worked really well side by side in providing for her, and ultimately we received admission of liability a couple of months in, and we switched to a single instruction of Lisa, and I think once Mr. X was in and settled, then the rehab really started. I wonder if you can tell us a little bit, Lisa, about how you organised the rehab during the lockdown restrictions, and how Mr. X's day was structured, because obviously it was a completely different environment to that we've been used to pre-pandemic.
Yeah, I mean, we were really fortunate in that we were able to, we got the statutory, so the hospital that he was in Lymington, which was one side, and then we were over in Portsmouth, but actually Portsmouth hospitals had a fantastic reablement service, and the OTs from the NHS were able to work with us, and they came to Still Waters, and then they transitioned across to Portsmouth, where I was able to introduce my client to the team there. And as Ruth said, the statutory services for those early days, I'm a great believer in the NHS, and I truly believe where we can utilise it, we should. And she's a great example of where the NHS and private dovetailed beautifully together, and they were really, really grateful for that top up, because the problem with COVID was that the hospital kept closing down, her appointments were stopped, hospital transport was a nightmare, so I had to go back to the solicitor to say, can we order a taxi, because she was missing her appointments because the transport wasn't turning up, all the usual problems with kind of statutory services, but made worse by COVID. But I think, you know, that whole MDT team worked really, really well. I think Ganesh will be really proud to hear that I was pleased with all our discharge summaries that we got from the NHS. But the downside is that they had to agree that it wasn't enough for her. So we, again, at Still Waters, they're very close to a private centre that had a hydrotherapy pool, and we were able to get a private physio and a private OT to start engaging her in some meaningful activities, because I think following amputee, it's the big psychological issues, and she was hugely anxious, or he was hugely anxious, sorry, and found it really, really difficult to come to terms with the sudden traumatic loss of a limb. So, you know, engaging some early psychology was something that we looked at for him as well. So I think, you know, statutory services were providing the best provision that they could at the time. But unfortunately it wasn't quite enough, and so we did have to dovetail in with some private, but I think it worked really, really well. And I think, you know, it mainly, our biggest problem was getting equipment from out of area, but we managed to get all of the equipment in from statutory services, even though it meant our team driving up to stores to pick it up because they couldn't get the transport to us to bring it. So it all came together in the end. So shower chairs and things all came, hospital beds arrived, and all, as I say, in the thick of lockdown. So and I think the important thing here is that the family were so grateful, because they were themselves terrified of COVID. So we had to have a very clear COVID policy. You know, they didn't want anybody entering that property unless they had fully gowned up and masked. So we fortunately worked with our colleagues to get enough PPE, because that was a big problem at the time as well. Getting PPE was really challenging for those of us in the community, but the good old CMS UK colleagues of mine came to my rescue and helped us out. So it came together in the end, didn't it, Ruth?
It did. I'm probably continuing that theme of reflection. What do you feel as a case manager you learned from adapting to working during the pandemic, and what things will you take forward in terms of rehab and your role as a case manager?
Yeah, I think some things, I am the eternal optimist. I mean, my glass is always half full, and I always try to see the positives in anything that happens. And I think for us as a company, actually, what the pandemic did for us is it really took us up to the next level of where really we needed to be. So electronic notes, so we set up electronic notes, so we were getting live streams of notes. We set all of our clients up with laptops, and we made sure that the support workers had their own email addresses and they had SharePoint so they could see our care plans. We did you know, really regular supervision to make sure that they were feeling okay. And what we've pulled from that really is that supervision doesn't really have to be live. I mean, you could save quite a lot of money actually. MDT meetings, we don't ever do face-to-face MDT meetings now, because it meant that Ruth was able to come in on the MDT meetings from time to time when she felt it was appropriate. We've had more people from the NHS turn up to our MDT meetings, and we've been able to dovetail NHS and private people together, which is, you know, great. And I think the new the NICE guidelines are going to hopefully allow for more collaboration between statutory and private services. So I think for us, the IT side of things moving forward, I recognise that we gain so much more when we see patients face to face. So I don't think that we can say that, you know, doing everything remotely is the be all and end all, but I certainly think it cuts down a lot of that travel time once you've seen a client, and for us setting up IT systems. And I think asking solicitors and deputies to give some consideration to a really good, robust IT setup, perhaps with, you know, bit defenders for those that are vulnerable. But I think all of those things have become quite a priority in our INAs, whereas before probably the IT features weren't so high up. So yeah, really happy with some of those things. So that I think that's what we've learned, and we've really learned that great collaboration with the NHS and having a real empathy and understanding for their journey and how they are restricted, and me just speaking to the NHS in a way is, you tell me what is needed and we will see how we can fit and how we can help with that. So it worked quite well.
That's great. I think, yeah, I think from my perspective, as solicitor, I think it was that ability to have those virtual meetings so quickly.
Yeah.
We were communicating, you know, over text. I mean, flexible working at the time and working out of hours, but it just
Ruth calling me at 11 o'clock at night.
We could work with so much speed, momentum to get that rehab in at the right time, when everything was so uncertain. I think that brings our kind of chat to an end. And sorry, I'm just looking quickly down the slides. We've had some questions, so I'll have a look and see who they're for before we pass back to Natasha, and we go up to the top. Were the prosthetics needed more expensive than those normally provided? As part of the claim process, we looked at private provision of prosthetics.
Yeah, I think the thing is, in what we did at the time, and I'm a great believer in that very early amputees, particularly when it's a traumatic one, not so much when it's a planned amputation. I think during, you know, with trauma, there's often lots of other complications, and so, you know, sticking to that you know, NHS model works quite well. And then what you do when you want to go further down the line to have colour matching and, you know, little hairs and the beautiful things that we can offer, you know, that can then be taken care of. And I think we went to Dorset for that, to look at colour matching, to look at silicone, to look at assisted you know, devices for her. So I think, you know, from my point of view, if you can get the early rehab in with a reablement service, you know, that's undoubtedly, you know, the best way forward, and top it up with private.
Another question, when you assess or review a patient digitally, how can you ensure that you are practicing safely? I guess that's more one for you, Lisa.
Yeah, I mean, obviously from our point of view with this particular case, I was I guess fortunate in that I became a bubble with the client, because we actually have still waters as an environment that we're able to go to. So I was actually in a kind of bubble, so I was able to see the client myself, and so that was great. So any assessments that were being done, I was able to facilitate and be part of. In terms of the OT would come in, so we didn't do everything virtually. When it came to the actual rehabilitation, you can't virtually say, you know, pop on a prosthetic limb. I mean, we had to physically do things. So I think the initial bit, we were relying really on medical records and speaking to doctors and medical teams. So
yeah, got to do.
In terms of exercise, I mean, I guess the question to that is, one thing that we did do, it might be helpful to know, is there's the portal, which is a device that we've got for a lot of our clients, and when they were doing their physios, the remote sessions for the physiotherapists, the physios were able to then watch the clients do their exercises. So yeah, that kind of thing was really helpful. But there's no two ways about it. You know, with an amputee, you need to have hands-on therapy. You know, absolutely.
Yeah, absolutely. Okay, I think it's probably time that we hand back to Natasha, ready for the next speaker.
Great, thank you very much, Ruth and Lisa. That was great to hear all you've done for your client, and also to the other speakers for sharing their case studies with us. We're now joined by Jude Hammer, and I'm really excited about speaking with her and asking her a few questions. They're not going to be too difficult. She's a Great Britain wheelchair basketball player. Jude is also an amputee, following more than 20 unsuccessful operations to even out the length of her leg. If you have any questions for Jude, please send them through, and if we've got time, I'll try and ask her them. Jude, thank you so much for joining us today. Within that's good. Within, I think, 2 years of joining Exeter Otters Club, which I think is the greatest name for a team, it's brilliant. You made your international debut at the 2009 BT Paralympic World Cup. So, I mean, that's really quick. So tell us about how you got into wheelchair basketball.
So it was not long after I had my amputation. I chose to have my leg amputated after, you said, I had a lot of operations during my childhood, and had varying levels of success with that, and got to a point where I decided that amputation was better for me, just because I was 15 at the time and I wanted to start being able to live my life and not being in that hospital all the time. I spent nearly every holiday as a kid in hospital having some sort of surgery, and it wasn't getting me anywhere, and I wanted to be able to do things. So I had my leg amputated when I was 15, and I decided at that point that I was just going to say yes to everything. So there was a girl at my school who was playing wheelchair basketball at a local club, and she was talking about it and how amazing it was. So my PE teacher took me down to a session at this club with my dad, and I just played in my NHS wheelchair with the handles on the back and the massive brakes, and I loved it. It was amazing. I can't run, I never have been able to, so it's the first time I could play sport and really feel like it didn't matter about my leg, and it didn't matter if I fell over, and I could just play and not worry about any of those things. So very quickly it became like the highlight of my week. Within a year or so, one of the guys that I was training with got me into a junior tournament that we have. It's just like a regional competition between all the junior players, so he got me into a team for that, and I kind of accidentally fell into the GB team from there, really. The GB coach was there watching, and he invited me along to a camp. One of the girls who was playing, I was staying at her house, so she was taking me back to the train station after the day, so he said I could join in for the day, and this was before Beijing. So I was playing with them. I had no idea what I was doing. I was being coaxed the whole way through it because I had no idea what was happening, and he told me at the end of that day that I wasn't going to go to the Beijing Paralympics, which at that point I had no idea what they were, really. I didn't know there was a Paralympic team. I didn't know that you could play for Great Britain when I started playing. It was just because I loved the sport. I went away from that day and started watching what I could of the Beijing Paralympics on TV, which was limited at that point. But I watched the little bits that I could and loved it and wanted to be a part of it. And then, within 6 months of that, I was at my first international tournament, and I have played every major international tournament since.
Yeah, brilliant. Oh my gosh, it's absolutely amazing. And I mean, you spoke just briefly there about the Paralympics and you not knowing anything about them, or if that was an option for you when playing wheelchair basketball. Was that something you were thinking, oh, this is a sport I'm going to achieve in? Because you went to the European Championships, didn't you? And the team has done so well is kind of winning. Is that did that get into you? Did you think I've got to win stuff because you've gone on far? How have you enjoyed that? Winning is brilliant.
I love to win. I'm very competitive, always have been, and could never really find an outlet for that as a kid. I guess like my family, my dad's Welsh, so rugby is our sport, and I couldn't play that as a kid. So my sister played. She played that. She played football, and I'd always go and watch her do those things, and I couldn't play, or I could play in goal, and that was all I could do. So I never found my sport when I was a kid. So yeah, basketball was the first time that I found something that I could do, and it didn't matter about my disability, and everyone was like me. So it was just just really enjoyed it. Just felt like I fitted in somewhere. The competition is definitely one of the things I love about it. Basketball is one of those sports that you never get good at. No one is ever perfect at it. And I think that's what I love about it, is that you have to work so hard all the time. There's always a challenge. There's always something new to learn. The women's game has developed massively since I started playing. It's much more physical and aggressive than it ever was when I first started playing. And I love that. I love that it's always a challenge. And yeah, the team's just gone from strength to strength. When I started playing, it wasn't a given that we would qualify for World Championships and Paralympic Games. And now we're second in the world and second in Europe. So yeah, we're really improving.
Exactly. Brilliant. And you mentioned earlier about having to undergo an elective amputation when you were 15 and having to make that journey and make that decision and being so young. But how did you find like the rehabilitation, especially after the surgeries? What was offered to you? What could you do? And then the rehabilitation once you've had the surgeries?
I guess rehabilitation after my surgeries was limited, I suppose. So my disability that I was born with is PFFD. It's proximal focal femoral deficiency. It's quite rare. And when I was born in the later end of 1990, before Google was really a thing. So the doctors had to go away and they had to look in books and fax people to try and find out what was wrong with me. They knew something was wrong with my hips, but they couldn't figure out what it was. It took a long time, it took a few days to do that. And I was born in Plymouth, my specialist was in Sheffield. So there was a lot of toing and froing to take me there because they couldn't, just email x-rays across to each other. So my initial surgeries were, the rehabilitation was quite limited from those because there wasn't much known about my disability. I would say that my surgeries were very much trial and error at some points. So a lot of it was, I'd have my leg broken in the middle in the femur, I'd have pins put either side, and I'd have a frame on the outside, and then they would, my mum would have to turn an Allen key on the outside of this frame twice a day to make the gap bigger, and then the bone would grow in between. And pretty much all I remember after that point from having the frame removed would be that the rehabilitation to get back to be able to walk would be, can I bend my knee so I can put my foot on the floor, and can I walk again? Can I weight bear on this new bone? And that was pretty much all I had really going up past after those surgeries. I think because my hip was so affected as well, there was probably a little bit of acceptance that maybe my walking would never be great. So it was just however I did it was however they left me to do it. So I was never taught to walk properly by anybody post those surgeries. It was just kind of like, if you have movement in your hip and your knee, then leave you to it from that point, because I didn't know a whole lot more, I guess. Rehabilitation after my amputation was really tough for me. I had quite a few issues post amputation. I elected out my amputation in May of 2005, and I was told that the normal time length from amputation to walking again was about 6 weeks. Mine took about 4 or 5 months. I woke up and I had the end of my leg had been stapled shut rather than sewed shut, which was just horrific for all my family to see. And the staples kind of like started, the end of my leg just kind of started to die. So I had to have months of A&E visits and plastic surgery visits to have the end of my leg tidied up and have it re-sewn back together, I guess, before I could walk again. So it took me about 4 or 5 months before I was even allowed to walk because I kept having necrotic tissue. At that point, my rehab was pretty quick because I didn't have pain in the end of my leg because it had been so long since I'd had my amputation that I didn't have to. So normally when you have an amputation, you use like a PAM-aid and things like that to learn to walk again, but I didn't need to do that for quite so long because I didn't have pain like a lot of other people do. I could walk on my prosthetic quite quickly because I didn't have that sensation through the end of my leg. So I think it's meant to technically be like you start for half an hour on your leg and then you build up half an hour every day. I did half an hour on the first day and then took my leg home the next day and walked for 7 hours because I was just very determined that was all I ever wanted, was I wanted to have my leg and I wanted to be able to. So when I grew up, I had a built-up shoe, and when I had my leg amputated, I had about 4 inches of discrepancy between my legs. So all I ever wanted was to be able to have 2 feet on the floor. So when I finally had a leg, I just wanted it. I wanted to go home and I wanted to just do it. I didn't want to have to do all of the walking stuff. Like, it felt fine. I wasn't in pain. I wanted to just get on with it. So they let me go with it. The prosthetists were amazing when I first had my leg amputated. They were really supportive through my whole decision to have my leg amputated. They showed me all the options. They helped me choose what I thought would be good for me to have in a leg before I even had my leg amputated, so they could hit the ground running when I had it done. And they, were really supportive of me just kind of going on that journey as I felt sort of fit for it. So for a lot of people, I think it takes them a long time to build up tolerance, but because I felt so good so early, they just let me do it because I was young and fit and I wanted to, and it wasn't causing me any problems. So yeah, I don't think I did it the conventional way.
That's amazing, just getting up and going. You were ready to go. But just quickly, because I've previously spoken about elective amputations, did you get any support to make the decision to have the amputation, and then the plan for you with the rehab? Obviously the necrotic tissue and the plastic surgery delayed things, but did you feel that you were supported in that decision?
Yeah, I was definitely supported. So my mum was the one that suggested. So I was going in to see my specialist about having more leg lengthening. So we'd had to take 3 years off leg lengthening before my amputation because my hip had dislocated. So I'd had to have that fixed before they could look at leg lengthening again. And the specialist had come in to speak to me about that. And we're talking about the varying levels of difficulty that was going to present itself with because of my hip being so weak at this point. And I'd also had a bone infection as well. So my mum at this point said, well, what about amputation? Is that something we could consider? It wasn't something I'd ever wanted to do. Had always been told that I would have 2 legs the same length by the time I was 16, and that's what I was sticking to. I never wanted to have an amputation. But very quickly after that point, I thought actually maybe this is a route I should consider. So the specialists were amazing. They got me psychological support. They got me in with various prosthetists so I could speak to them about options and what would be the right amputation for me and what that would look like in terms of prosthetic legs. So I knew what it would look like beforehand. And my family had psychological support as well. And they were, everyone was very. It was about 6 months between that conversation and having it done, and the whole time I was having support and being asked a lot of questions over whether I thought it was right and what it meant for me, and that I was definitely sure that I wanted to make such a life-changing decision.
Yeah, no, that's brilliant. I'm glad you have that support, because there are some people who haven't even got access to speak to other amputees before they have the amputation, and so it's really good to hear that you had that support and family support as well. As part of your rehabilitation, I know that you trekked across Ecuador as part of it, and I think there's a program, a BBC program called Beyond Boundaries, documenting that achievement. Can you just tell us a bit about that? I mean, that's some amazing rehabilitation. I mean, that's getting out there.
I think, that goes back to me being very competitive and not wanting to say no to anything. I think being an amputee made me feel like I fitted in, I guess, like having one leg shorter than the other. When I was a child, just I didn't know anybody like me. I knew of people who were under the same surgeon as me, but I didn't have any friends in my day-to-day life who looked like me. I didn't know anyone with a built-up shoe that I could talk to about it. So being an amputee made me feel, I guess, more like I fitted in, because you see amputees more often than you do people with build-up shoes. And as a teenager, that was really important to me. And it made me feel like I could just say yes to things. And we saw this advert for Beyond Boundaries, for the new series, and yeah, I applied, had a phone call, went in for an interview into their offices in Bristol, and within a month I was on a plane to Ecuador. I think now, like 16 years later, I definitely would not do that again, because it was just like, it was an amazing experience, but it's just a crazy thing to think, like, yeah, I just went halfway across the world with people that I had met once and just hoped that it would be okay. It was hard, yeah, really challenging. The experience itself, I think, is probably, I don't know if I would do it again. Physically, it was very demanding, probably the hardest thing I've ever done. We walked about 10 kilometers every day. I can't walk without a crutch. So I had to use walking sticks the whole way, and it just, as a 16-year-old, it was really challenging mentally as well, to be in a situation where that much pressure is on you and other people to do this really hard task between you. And it made me really look at myself and what I was capable of physically, and I think that probably was a good thing for me to start to understand some limitations. Having limitations isn't necessarily a bad thing. It just, there are some things that my body just can't do, and yeah, I'm glad I did it, but I think more for the lessons it taught me than for the actual physical challenge, because it was very hard. It was amazing though. It's a beautiful country.
Yeah, no, that's absolutely amazing, and I think just what you said about the challenging things you do when you're young, but you
why did I do that?
Yeah, exactly. I think but then I see wheelchair basketball, just hurtling yourself at other people in wheelchairs and smashing about. I mean, that is just as intense. How do you encourage people, young people, to join such a sport? Do you just show it to them and they're straight on it, or how would you suggest? We've got some case managers on here who've probably got people who suffered amputations and want to encourage them to kind of go forward in sport. What would you say? What do you think is the best advice for them?
Well, technically it's a non-contact sport, so that's always, I say that as I'm managing a concussion, but it is technically non-contact, so so that's something like for people. Normally people only the odd like scrape here and there, but it's not as brutal as it looks. It's not like rugby. Wheelchair rugby is something else. I think, everybody that I've ever met who's ever played it, watched it, just loves wheelchair basketball. It's just, it's the thing that I love the most about it, I think, is that anyone can play. In our national league, you don't have to be disabled to play. So we have, siblings come and play with their brothers and sisters, so they all get to play, and they, I've met people who've come along with their disabled brothers and sisters when they were like the same age as me when I started 14, 15, and now they still play now, because it's just one of those sports they love, or they got into it because their mum or dad plays, so they play as well. And it's a real family sport like that. It's amazing. And I think we're starting to get to a position now where it's on TV a lot more. So we have a new Premier Women's League where we have 4 teams playing against each other in a league, and those games are on BBC Sport on the red button, or they're also on YouTube if they're not there. So it's easy, it's much more easy to access to watch it nowadays as well, which is really cool. To get our sport out on TV like that is amazing. I watched a game last weekend that was on, and there were 200 people, I think, watching it on YouTube, which was just amazing for a women's sport, a women's disability sport in this country. It's just really exciting. So I would encourage anybody to go onto the British Wheelchair Basketball website, look at where your local club is. There's usually a game on YouTube or the red button at the weekends at the moment, so there's always something you can watch. And just give it a go. a lot of clubs now have a couple of chairs that they can give people out to try it, so you can get involved and give it a go for a session. Yeah, and it's just amazing.
Brilliant. Oh, well, I think encourage people, and I think getting friends and family involved as well it's a really good initiative. Just finally, what's next for you? What's next for you in sport, for yourself? What's going on?
What's next for me? So at the moment I'm rehabbing, so I'm dealing with my concussion, and then I'll be back playing in the league. So I'm playing for 2 clubs this season, a Premier Women's League team and a mixed men's and women's team. So I'll get back into that, and I'm aiming to win both league titles this year. That's the aim with both clubs. That'd be really amazing. We hopefully have Commonwealth Games coming up this summer. I have committed to playing for Scotland because my mum's Scottish, so there's a lot of rivalry in my family when the rugby's on, like Wales and Scotland. So we have qualifiers for that in the summer, and then we obviously have the Commonwealth Games, so going for a medal there as well, which will be the first ever wheelchair basketball event, so that'll be really cool. We have World Championships in November. We just came second at the European Championships at the end of last year, so aiming to hold on to our second place in the world as well would be really cool going into the Paris run-up.
Oh, brilliant. Oh my gosh, there's so much to come. And yeah, Commonwealth Games in Birmingham, I mean, we can all get there, so let's get some tickets and see Jude in action. Brilliant. There's not been any questions coming through, but thank you so much, Jude. If people do want to know more about wheelchair basketball, I'm sure Jude will point us in the right direction, and be happy to answer any questions. But no, thank you very much for joining us. Now it's come to the end of this brilliant conference. I hope we've done what we said we were going to do, rethinking rehabilitation. Deirdre and I would just like to thank you all for joining, and we hope that you found it informative. Thank you to all our speakers. Their contact details can be found in the Q&A box on your screen, along with our feedback survey. Please do fill it in, as it does help us shape our future events. We are planning a face-to-face conference on the 19th of September in London, and so we'll be able to see everybody and lovely faces. We're really excited about it, and we've still got some room for speakers and things like that. So if there's anything you want to hear about in the rehab conference, please let us know, and we'll do our best to facilitate that. Nothing else from me. So,
we'll see you in September, won't we, Natasha?
Yeah.
Back on Natasha's home ground. So thanks so much, everybody, for coming, and we'll see you face to face over coffee in less than 6 months, is it? I think so.
Yeah. Thank you all, and have a lovely afternoon.